In today's episode, we break through the complexity of women's health with a masterclass featuring Professor Susan Davis, Dr. Stacy Sims, and Dr. Jen Gunter. Together with these three brilliant minds, we'll take you on a deep dive into the intricacies of menopause and the effectiveness of hormone replacement therapy. We unravel the biological and emotional tapestry of menopause, from its early onset and symptoms to the proactive management of its progression.
I classically get a patient comes to see me and says, made this appointment 3 months ago. Oh my God, I couldn't sleep. I hadn't had a period for months. I was so anxious. And for the last 2 months, I've had regular periods and I feel fine. I'm not even sure why I'm here, but then I thought I should come.
Our experts shed light on the impact of hormone replacement therapy on cognitive function in women over 50 and 60, the role of exercise in maintaining bone density, and strategies to combat common symptoms such as night sweats and weight gain.
When we're looking at body composition shift, we see that it is affect of less response of these estrogen progesterone receptors, as well as a change in the gut microbiome. When we see one of the first telling signs is women will lose power and strength.
Would you say that HRT makes it easier to maintain strength and lose weight? Additionally, we explore the specific training and nutrition needs of women in their 60s, debunk myths surrounding menopause testing and bioidentical hormones, and discuss alternative treatments for symptom relief.
Yeah, so you don't need any blood work for perimenopause, the menopause transition. What you need is somebody to talk to you about what's going on symptom-wise. So if you're starting to get a new onset of irregular periods and you're 46, that's expected. Just like if you start growing when you're 9, no one's going to say, wait a minute, why are you growing? Well, we all expect puberty to come at that time. But if you started growing when you were 4, then people are like, wait a minute, that's the wrong time.
My hope being that this masterclass equips you with a holistic understanding of women's health during menopause, offering expert guidance for a confident and proactive approach to this natural life stage. Enjoy. What is menopause? Let's define a few terms here. Maybe that will make sense. Like perimenopause, menopause, premenopause. What do these terms mean? And what's the kind of timeline? If you were to sort of explain to a woman, these are the phases that you'll go through where hormones are changing in your body.
So formally, the menopause is the last menstrual period a woman experiences as a result of her ovaries no longer producing eggs. Now, obviously that works if someone's having regular periods before their menopause. But if you've had a hysterectomy or you've got an particular kind of IUD and endometrial lining removed, that's not going to apply to you. But that is the definition of the menopause. And a woman is considered to have completed menopause, gone through menopause if she has not had a menstrual bleed for 12 months. That's the traditional belief. Now, obviously, we can't use that in a woman who's had a hysterectomy. Say you have a woman has hysterectomy at 45, but her ovaries are still working. She hasn't gone through menopause. So a more perhaps modern definition is the ovaries run out of eggs, can't produce an egg to release into the uterus to be ovulated. That's the menopause.
So can you clarify that with regards to a hysterectomy? Some women will have a hysterectomy and their ovaries will still be producing eggs. In other scenarios, that's not the case.
So if a woman has a hysterectomy before she's gone through menopause and her ovaries are not touched by the surgeon, the hysterectomy is not causing her menopause. The hysterectomy is simply removal of her uterus or her womb.
Got you.
And the ovaries can continue to work for some time afterwards, depending on the age of the woman. Mm-hmm. If a woman has gone through menopause, and let's say at 50, and at 55 she has a hysterectomy, she's already stopped her periods anyway.
What would be the indication or reason for why someone would have a hysterectomy and the ovaries are removed versus are not?
So some women will have a hysterectomy with their ovaries removed, and when the ovaries are removed before a woman's entered her natural menopause, we call that surgical menopause. There are reasons for that if women have extensive endometriosis, for example, or if they're found to have changes in their ovaries, like lots of cysts, and they've got heavy periods. So there are multiple indications. And of course, Sometimes it's due to malignancy, due to a cancer of the uterus. Sometimes a woman will have her ovaries removed if she's been diagnosed with breast cancer and it's part of the management. So there are lots of different reasons.
And in a sort of normal context, a woman hasn't had a hysterectomy. What's the average age for menopause again?
The average age for menopause in Australia, up until recent years, because we are having a demographic shift, is 51.5 years.
51.
And that's a bit high compared to most countries, but in if you go across the world, the age range for menopause is between 47 and 51. So when you think about it, we're only talking about a 3-year difference. So around that age is the average age of menopause.
What about like use of hormones in premenopause? So using birth control, for example, would that affect that window at all?
There's been no evidence to date that use of the oral contraceptive pill or any other form of contraceptions meaningfully changes a woman's age at menopause.
Okay. And so a woman sort of enters perimenopause, and what's the typical age for that again?
So with the average age of menopause being, let's stick with 51, not 51.5, the menopause transition usually commences about 2 years earlier, but maybe a bit earlier. So it's always an average. So if I say 2 years earlier, some women might be 3 or 4 years earlier, and some women might have a very short menopause transition. We're talking averages. And for a woman who's having regular menstrual cycles, the first change a woman will notice is menstrual bleeds become either heavier or lighter or less regular. Might be 3 weeks apart, then 6 weeks apart, then 3 months of regular periods, then 2 months of no periods. So the change in the frequency of menstruation combined with the degree of bleeding.
When we talk about menopause and the symptoms that come with menopause or can, and I appreciate they're going to vary from woman to woman, they'll each have their own experience, but are most of the symptoms in the perimenopause phase, and because often I hear I'm going through menopause. Is that speaking to the perimenopause phase? Is menopause something by definition you go through, or it's something you reach and then you're sort of in menopause for the rest of your life?
Yeah.
And when are the symptoms? So if a woman's thinking, gosh, am I going to have these symptoms for the rest of my life? Or is it a sort of window where you experience the symptoms, you get to the other side, but then I'm sure, as we'll discuss later, there are some other changes that could affect chronic disease risk, long-term risk of things. Can you kind of shed some light on that?
Okay, so I'm going to put this in the context of a woman who's having regular menstrual cycles. There might be 30 days, okay? Not 28, 30. Every 30 days, she can pretty well predict her period. When her bleeding becomes either lighter or heavier, so scanty or very heavy bleed, and she notices her period's no longer 30 days, they're going 2 weeks, then 6 weeks, whatever, she has entered the menopause transition. Mm-hmm. And that continues until the day of her very last menstrual bleed. And at that point, she has hit menopause. But she doesn't know that until a year later. Mm-hmm. And she looks back and says, I haven't had a period for a year. That day, when I wrote in my diary on the 25th of January, 2023 was my last menstrual period, that was my menopause. This is like we're making our little textbook woman. And that is the end of her menopause transition. Mm-hmm. Her perimenopause is defined as starting at the time of her menopause transition, when the periods become irregular, until a year after her last bleed. Mm-hmm. So from the start of change till a year after the last period is called the perimenopause. On average, it's about 3 years, maybe 4 years. And so when we talk about the menopause, that's actually a moment in time. And from that moment, a woman is post-menopause.
Mm-hmm. Got
and
you.
peri is around the time of change.
Got you. A moment in time, menopause. So with the symptoms, hot flushes, and I might get you to define that. I hear hot flushes, I hear hot flashes. Not sure which is the right way of saying it, but those symptoms, are they mostly experienced during the perimenopausal phase when is it a sort of there's greater volatility of changes happening with hormones, and then once you reach menopause at that moment, and now we're into post-menopause, we're starting to see less of those kind of acute symptoms and disruptions to sleep and mood?
So around this time of change, from the beginning of symptoms and irregular bleeding to a year after the last period, which we call the perimenopause, this is a time of hormone chaos.
Hormone chaos. So
but one woman's hormone chaos may not map to another's.
Okay, but this seems like it's something that partners should listen to.
Well, yes. And some women, I classically get a patient comes to see me and says, made this appointment 3 months ago. Oh my God, I couldn't sleep. I hadn't had a period for months. I was so anxious. And for the last 2 months, I've had regular periods and I feel fine. I'm not even sure why I'm here, but then I thought I should come. And that's classic.
That's like when you break something on your laptop or phone, and then you book your appointment and you go into Apple and you show them, and all of a sudden it's working perfectly.
Yep. So you can have weeks to months of really low estrogen and horrible symptoms, hot flushes, night sweats, irritability, anxiety, and then boom, periods come back, your ovaries start working again, and everything feels normal. And this can happen on and off for the 2, 3, 4 years. And other women, they have regular cycles, bang, never have another period, and they never had this horrible experience.
Do we know why the variability? Why would it be, not smooth sailing? I don't want to say that, but why would it be, relatively speaking, it's easier for one woman than the next?
I make it akin to childbirth. I've had 4 kids. Every pregnancy was different. Every delivery was different. It's just our biologies differ our biology, our own personal biologies differ over time. And between women, there's huge differences, but there's no simple explanation.
Okay. Before we get into the physiology and what's happening to these various sex hormones, that's kind of underpinning a lot of what we're talking about, I want to kind of understand the human experience here. So you're a woman, you work clinically as an endocrinologist, and we were chatting off air. We had a laugh. My mother has seen you at some point, so there's a bit of a connection there. So you would hear a lot of stories, and you're connected not just to the data that we see, and if you give someone estrogen plus progestogen, what's the outcomes? That's really interesting and helps us, make a good sort of risk-benefit calculation. But from a human experience side, take us inside a woman's life, her mind, as she's transitioning through perimenopause. She's experiencing changes physiologically. How is this manifesting in terms of how she feels about herself, what her worldview is, how that's changing, where she fits in, her connections with family or disconnections with family? I'd love to explore that.
So there's a huge range of experiences, and I think that's incredibly critical to understand. And some people become zealots about their experience and write a book and expect everyone to identify with their experience. And I think that can be really helpful, but it can also be confusing. Some women will 25% of women have virtually no symptoms, 20 to 25%. It's not a big deal. Doesn't mean that there aren't changes that are affecting their biology that we can talk about separately, but for about 20 to 25%, it's not a drama. They don't get anxious. They don't get depressed. Their sleep's not different. And then there are the women who have migraines every month, and then suddenly they're like, oh, this is such a relief.
And that's despite, if you drew their blood, you would see a very similar hormone profile.
Yep. And there are other women who, the classic symptoms are hot flushes and night sweats. And then I have patients who say, I've never had a hot flush. Do you feel hot? Oh, I'm just hot all the time. So even the way women will describe their experience of the heat is variable. Some women have terrible flushes during the day, but not at night. Other women literally have to change their bedclothes because they've sweated so much on their sheets they're lying in a puddle. I think our research has shown that women understand this. I think one of the more, dare I say, even more sinister symptoms that women often do not relate to menopause is anxiety. Irritability they get, they often talk about the 7 dwarfs, the sort of the grumpy, the bitchy, the this and the that. But anxiety can be a real symptom of menopause, where women become irrationally anxious about something minor, panic attacks, and women don't link that to their menopause, so the bells don't ring, and the trigger doesn't go off. So they feel alone, vulnerable, because they don't know what's going on with their body. So a lot of how women experience the menopause, if you're empowered with knowledge about what may happen, you can say, oh, this is happening to me, understand why it's happening. If you don't know why it's happening or what to expect, it's a very frightening and lonely experience.
Mm-hmm. Do you think women feel embarrassed?
I think it depends on the degree of knowledge a woman has and her social group in terms of family, friends, and work. So and the confidence of that individual. I think where women commonly feel embarrassed today is taking HRT. So I still have patients who say, I don't tell anybody I'm taking HRT because they're all going to come at me about, oh, you shouldn't be on that. Did you know it causes breast cancer? Blah, blah, blah. I find women are more embarrassed about that than actually mentioning to friends how they feel.
How good are the available interventions and the recommendations that we have?
For what?
For what we're talking about at the moment in terms of the hot flushes, the changes in libido or mood, these more acute things as a woman is going through the perimenopause, if she is one of those, I think you said 25% experience very little symptoms, but if she is one of those that is experiencing symptoms, does she have to experience those symptoms? Is that a given for her?
Okay, so there's a lot of talk about the perimenopause and the menopause. There are many women who actually don't have terrible symptoms in the perimenopause, but because their ovaries are intermittently working. And soon as they hit the menopause and their ovaries, their estrogen just drops through the floor, that's when their symptoms are horrible. So there is a variation as the timing of individuals. So let's talk about the post-menopause. A woman's ovaries have stopped working. Hot flushes, night sweats, vaginal dryness, sleep disturbance, anxiety, low mood. I'm saying low mood, not clinical depression. Estrogen is incredibly effective at alleviating those symptoms.
What's the difference between low mood and clinically diagnosed depression?
Clinically diagnosed depression is really continuous loss of the ability to find pleasure, to black mood. There is at least 2 weeks of, severe down mood. Nothing makes you happy. You don't want to get out of bed. You can't communicate with people. It's profoundly severe. Now, it may be exacerbated by the menopause, but before you just throw hormones and say that you should be responding, there are people with clinical depression who are not going to get well with hormones. And so it's a very important thing that if mood doesn't improve with hormones, then you need to start looking at other more profound depressive illness. But moving away from that, low mood, just not feeling, women will say, I've lost my mojo. I'm just not as happy. They're not getting out of bed. They're just saying, I'm just not happy. I'm not laughing as much. I'm anxious. I'm irritable. That's very responsive. Now, and that's fairly straightforward to treat in most circumstances. But when we're talking about the perimenopause, women are intermittently making an egg and having their own bleed. And the hormones are going up and down. So one day the estrogen is extremely low and the next day it's extremely high. One day they're sweating and the next day they've got sore breasts and bleeding. If you give standard HRT to that patient on the days where their estrogen's high, you can actually make it worse.
Right. So it's much harder to intervene if it's being very volatile.
Yeah. And you can actually worsen symptoms.
Does that happen? Would anyone prescribe at that
Well,
phase
some
of
people
someone's
do,
life?
and you can actually, in the old days we used to, and we used to find we often make symptoms worse. And what we also do is we cause the onset of a bleed with our artificial regimen, and then they ovulate and have a bleed. And then they're bleeding and not bleeding, and then they don't know when they're bleeding. And so and also at this time, women often need contraception. So a common practice in Australia is to give a low-dose oral contraceptive pill. And we're very fortunate that we have contraceptive pills here that contain the identical estrogen that we give as HRT. So there's a whole range of things we can do that will give cycle control, contraception, and symptom relief that is not yet HRT.
Right. Okay. So perimenopause, different set of interventions than the post-menopausal period phase. And just to kind of, I guess, umbrella everything we're talking about here, it seems like there's kind of two big buckets. Correct me if I'm wrong. You have those more acute symptoms that we're thinking about, trying to manage to make that woman's life more bearable, enjoyable, quality of life going through it. And then there's also we're forecasting out. So we spoke earlier about it's not natural to necessarily be living to 80 to 90 as a result of going or reaching menopause, being in the postmenopausal phase. These changes in hormones can predispose you to risk of different chronic conditions. Can we kind of just further define that? What are those chronic conditions? You sort of said estrogen goes off the cliff. So if a woman's listening and she's one of those that's fortunate not to have the acute symptoms, so thinking, okay, well, I got lucky, I'll just go through, I don't need to worry about any type of intervention. What I'm hearing is, well, actually you'd still want to pay attention because even though you're not experiencing symptoms, your hormones have changed and you could be placing yourself at increased risk of certain conditions later in life.
Before we get there, though, you do need to be aware that a lot of women think, oh, these symptoms are terrible, but I don't need to take anything because they'll be gone in 6 months. 42% of women aged 60 to 64 are still having hot flushes and night sweats. So although we describe them as acute, those terrible symptoms can last for decades. I see patients in their 70s who are still having hot flushes and night sweats.
And just assume it's normal.
Although they just think it's terrible, but they
have to put up with it.
Or we treat them for it. But
right.
But what I'm saying is, for many women, the average duration of symptoms is at least 7 years. So if a woman's having bad symptoms, a woman shouldn't think they're just going to go in a few months, because they're probably not just going to go in a few months.
That's a good point.
But for the woman not having symptoms, the changes that occur at menopause is bone loss. So even a woman with no symptoms, on average, women lose about 6% of their bone over that 2 or 3 years of transition.
Is that primarily because estrogen
Because
falls off the
estrogen
cliff?
is falling.
Right.
Women's cholesterol levels can change, so their cardiovascular disease risk changes.
Mm-hmm. As in it goes up.
It goes up. Women overall don't tend to gain weight, but even if without any weight gain, women tend to accumulate central abdominal fat. When you accumulate more fat around your tummy, that's bad fat, which is associated with inflammation, cardiovascular disease risk, diabetes, and some cancers, including breast cancer.
So is that, again, that's hormone related?
Hormone dependent.
Right.
So on average, women increase their central abdominal fat by about 20 to 40%.
Mm-hmm. You wrote a paper on that, right?
That we've described that, but there's actually studies that have specifically shown that that's not my research, that they've used techniques to actually show changes, doing scans annually across the transition and showing how much abdominal fat there is. And women's risk of diabetes goes up. So estrogen has incredibly important actions in terms of metabolic health and how insulin acts in the body. So when estrogen levels drop, women become more resistant to the effects of insulin, and so their risk of diabetes increases.
So let's dive into estrogen and sex hormones a little bit more here. So ovaries, adrenals, where are the sex hormones being produced? Estrogen, testosterone, progesterone, and perhaps just kind of an overview of how they're changing through this period.
So women have two major sources of their sex hormones. They have their ovaries and their adrenals. Now, the ovaries produce hormones with every menstrual cycle, and the main ones we talk about are estrogen, progesterone, which is the hormone that creates the possibility of pregnancy, and testosterone. And it is normal for a woman to produce testosterone from her ovaries. And in fact, testosterone gets converted into estrogen. So testosterone in the ovary gets made into estrogen in the ovary, and that helps with fertility. Meanwhile, while the ovaries are doing their things, we've got the adrenal glands producing sex hormones, the most well-known of which is DHEA. DHEA is released from the adrenal glands, runs around in the blood, and is taken up by other tissues, fat tissues notably, but also the brain, even the ovaries. And in those tissues, DHEA is converted into estrogen and testosterone. So what happens is you've got the woman premenopausally, ovaries and the adrenals all giving her hormones. When the ovaries stop working at menopause, or if they're surgically removed, a woman still has her adrenals. They continue to release DHEA, which then in tissues is made into testosterone and estrogen, some of which just only acts in those tissues, and some of which spills over into the bloodstream and goes into other tissues.
Right. But because the ovaries are no longer producing estrogen, that's why you get a net decrease.
You get a net decrease, so you get a major loss of estrogen, but the adrenals still produce quite a lot of hormone that will sustain biological function. Now, adrenal health varies between women. People often talk about this thing called adrenal fatigue. You have to have pretty rubbish adrenals for them not to be producing enough
I think I've seen someone
hormone.
post online that if you drink a couple cups of coffee a day, you might get adrenal fatigue.
Adrenal fatigue is sort of this wishy-washy thing that unfortunately people with fatigue are then told they've got adrenal fatigue and they're putting on DHEA or other things to boost their adrenals. And it's a lot of nonsense, really. The amount of DHEA that's produced is in buckets loads. There's plenty in everybody unless you've got adrenal failure.
In a woman's 20s or 30s, are there things that you can do during that period to kind of optimize your health or hormone status to improve your outcomes post-menopause?
So I'm not going to be politically correct. If I had a magic wand and I could wave it across Australia to improve the overall health of women, the menopause experience of women, and the health of women after menopause, it would be to reduce overweight and obesity. And in our study of 7,000 women aged 18 to 39 who were representative of Australian women at that age, 45% are already overweight and obese. And the figures vary, but over 55, 65% of women after menopause are overweight or obese. And that is the single thing that is impacting not only the menopause experience, not only pregnancy and reproductive health, but also health after menopause. And so we know that women who are overweight and have obesity have more hot flushes and night sweats and more severe menopausal symptoms. So that is one. And then you're going to have more cardiovascular risk. You're going to have more osteoarthritis. You're going to have more everything. So it is, apparently it's not politically correct to say it, but that is one of our major health problems in this country.
Yeah. I mean, I don't see that as politically incorrect. I just probably, I guess, solving obesity is more complex than maybe some people think.
Yeah, it's very complicated.
As you would know, there's a whole bunch of pieces to that, the food environment.
And the social drivers, the food, everything.
So,
but that would be the one
said
thing.
than done, but there are going to be some individuals who can, make changes, and it's good to know.
And what we know is that there is an age-related creep in weight gain that is not biologically determined, it's environmentally determined. So if a woman notices, I've put on a kilo, it's only a kilo. Don't say that. Say, I've put on a kilo, not good. I'm not going to get hysterical, but I'm going to change that. Don't wait till you put on 10 kilos because it's much harder to get away with to drop 10, and it's even harder to drop 20.
But what about the idea that, look, I'm 60, I'm 65, my metabolic rate has just dropped, that's why I've gained weight. Is there truth to that? Is it much harder for a woman to kind of balance her energy and stay at an optimal weight as she has reached that post-menopause phase of her life?
Oh, look, definitely that, as I've said, there are metabolic changes with estrogen dropping. If that woman's on an HRT, for example, she is going to be in a different metabolic place to a woman whose body's full of estrogen and other hormones. And
is she burning less energy just from a basal metabolic rate?
I can't answer that, because one of the things that really needs to be studied is we have white fat and brown fat, and one of my colleagues is desperate to do a study looking at burning of brown fat and whether it changes at menopause, and we don't know that, and we need to know that. But I suspect it does change from what the preliminary data suggests. But having said that, I think our activity changes, our subliminal activity changes, our dietary pattern changes, and I think that people are not sufficiently objective of their incidental activity and their incidental eating, that they don't really have a meal. I'll just have that biscuit, or I'll just have that snack, and it doesn't even register. And I'm not critical of people. It happens to all of us. But it's very easy for your incidental activity to drop.
Mm-hmm. I know that my mum's always seems to be baking me sweets now. Anytime I visit her, I leave with a big thing of sweets. Hey friends, if you'd like to stay connected and reinforce the valuable insights from this show, let's connect on Instagram. You can find me at Simon Hill. That's at Simon Hill. I look forward to seeing you there. All right, let's dive back into the episode. How are the guidelines for menopause constructed, created? What's the process, and why are they kind of important for us to consider, and important for physicians to refer to?
Perfect timing. We've got a big NHMRC grant to develop, update guidelines for health practitioners and embed them in algorithms into software. So what we've been doing, my extraordinary team, who I would like to acknowledge at Monash, we've done what's called a systematic search. So we have searched the literature for all the published guidelines, consensus statements, position statements since 2015 on menopause. And we have then used a process to identify how they've been constructed. Now, we found a small number, can't give it away yet because we haven't published the paper, but there are a small number that have been constructed using very rigorous methods. So, for example, when they've looked at what are the symptoms of menopause, they've done a search of the literature, and they've done everything's based on evidence. And they've done a very robust evidence-based, and they have described in their guideline how that's been done. There are other ones where people sit around the table and say, well, I think this, and my experience is that. And there's a huge dimension. So there are the good guidelines and the ones that still come up with the same ideas, but they haven't been constructed with the same rigor. So you end up with and often the best guidelines tend to come from medical societies that have membership with a great interest in this space, and they've dedicated some money to support the development and the methodology. What we've found is that, and they're important because if they're very high caliber guidelines, they really do bring together what is known and synthesized. And they say, this is what we know, this is what we don't know, and this is the maybe stuff, and this is what we know is bad. And what they consistently show from what we've done is that there's complete agreement in the major symptoms of menopause, which we've talked about already. The flushes, the sweats, the sleep disturbance. There's consistent agreement in that the most effective treatment for menopause is hormone replacement therapy. There's a consistent agreement that for a woman over the age of 45, if they stop having periods or their symptoms are a bit off, if they've got symptoms, you don't need to do blood tests. Women under 45, you should do blood tests. And then they start to diverge a bit about what should be given, because that's often guided by the country in which the guidelines developed and what's available. But in general, the guidelines indicate that for menopause with symptoms, the benefits of hormone therapy outweigh the risks. And then there's some subtle difference about whether hormone therapy should be used to treat osteoporosis or not, but that usually depends on whether it's approved in that country for that indication. So in general, they agree. Interestingly, they all consistently say that there's insufficient evidence that hormone therapy will prevent dementia or cognitive decline.
Which doesn't mean it doesn't, or it could
there
just be a lack of...
There is insufficient evidence to tell. You should not say to a person, you should be on hormone therapy because it'll help you protect you against dementia. The jury's out.
The jury's out. Okay. But there's not evidence to say that it doesn't or it makes it worse.
No, the jury's out. But therefore, you shouldn't prescribe it for that sole purpose.
Gotcha. Okay. So that's the hormone therapy side of things, which I want to dig into a little bit more and talk about some of the trials and breast cancer risk and all of that, the risk benefit kind of ratio. But what about in the guidelines? Do they discuss exercise or diet, or is there also insufficient evidence for those things?
There's no evidence that exercise will improve menopausal symptoms. The available data for exercise and bone health is just going for a walk around your local gardens is not going to cut it. You need to do exercise that includes impact. And you, of course, I suspect know all about that. Cognitive behavior therapy will diminish a woman's adverse experience of hot flushes and may reduce anxiety. So all the guidelines support the use of cognitive behavior therapy if it's accessible. It's not always accessible. It can be expensive, time-consuming, etc. The guidelines are very mixed in terms of phytoestrogens and black cohosh, really conflicting in what some say no evidence for benefit, don't recommend. Others say there may be benefit. When it comes to things like yoga, acupuncture, rhubarb, all those other things, no, there's consistent evidence of no benefit or lack of evidence. Acupuncture is one of them where the evidence is not there, that there's clinical trials have not shown benefit.
Does it frustrate you that it seems like there's an abundance of evidence to support hormone therapy for the right person, but some of these other things get more airtime or are pushed sort of more aggressively?
Yeah, I mean, I feel sorry for women who will spend a fortune on over-the-counter stuff that is of absolutely no benefit before they take hormone therapy, and you'll be horrified to know that our study of primary care physicians and pharmacists show that they acknowledge that most of the over-the-counter products are useless, but they will recommend them before hormone replacement therapy because that's what women want to hear from them.
Do you think this is a misunderstanding of the potential risks, like from an absolute point of view, putting them into context, what are they, and also perhaps not even registering the fact that, you know, a supplement, anything could come with a risk, and we probably should hold any of these compounds, or, you know, to the same sort of rigor of evidence that we expect if we're assessing efficacy and safety.
Yeah, I think everything that anybody's going to take for a symptom, particularly if it's going to hit your hip pocket, and that's, you know, I've seen people spend a lot of money on nonsense. I think everything should have clear evidence and for effectiveness and safety. And if it's sold with no evidence, women should be told the truth. There's no evidence of effectiveness or safety. From our research, and these are published papers, women will go for the alternative over-the-counter stuff first because their fear is breast cancer. And it's been drummed into women over the last 2 decades that basically you're pretty wimpy if you need hormone replacement therapy, tough it out, and the symptoms are going to go away. From the point of view of the healthcare providers altogether, gynecologists, primary care physicians, pharmacists, whatever, there are 2 things. One, they feel that women want to be told, you're a really good doctor if you do the natural therapy stuff, because there's the integrative doctor down the road. They'll go and see if you don't recommend it, and makes you a really good person because you're saying, well, why don't you just try that black cohosh first, even though you think it's not going to work, and they may or may not come back, and the placebo effect's fabulous. And also, they've told us, we don't know how to prescribe HRT. We're not confident. And we go down that path, and they come back with bleeding. We don't know what to do.
Right. So there's fear at the patient level, fear at the prescriber level.
Yeah,
here.
so it's a mess.
These are challenges, barriers. Am I right that a lot of this stems back to the Women's Health Initiative trials? Let's go through those.
In the 1990s, there was evidence to suggest hormone replacement therapy prevented heart disease. In fact, to the point that we actually did a study where we gave men with heart disease estrogen. And so in the US, a big study was set up called the Women's Health Initiative. And in that, there were 2 arms, one with women who had not had a hysterectomy, and they were given estrogen and progestin or placebo, 11,000 women. Am I going to have this around the right way? No, 16,000 women. Large study. And they were followed for 5 years. The other group were women that had a hysterectomy. They were given estrogen or placebo and followed up. Interestingly, that's the aim of the study was, does HRT compared to placebo prevent heart disease?
And why was one group given, was it progestogen?
So if a woman has had a hysterectomy, they don't need the progestin because they haven't got a uterus. Okay. We only give the progestin protect the uterus against thickening up.
Right. And so there was women in the study both that had a uterus and didn't have.
2 arms. One arm hysterectomized, estrogen versus placebo. Another arm, no hysterectomy, estrogen plus progestin versus placebo.
And you give them the progestin if they have their uterus intact because you want to lower the risk of endometrial cancer?
Uterine cancer, yep.
Gotcha.
So everybody got the same estrogen, conjugated estrogen in a tablet or placebo. And interestingly, it was predicted that there may be an increased risk of breast cancer. After 5 years in the estrogen plus progestin study, there appeared to possibly be a small increased risk of breast cancer. The safety monitoring committee had a little panic attack and they stopped the study prematurely. Bang. That wasn't seen in the estrogen-only study, which went out to on average 7 years of treatment. That study, there appeared that there might be a small increased risk of stroke. And because the other one had stopped, they had a little panic attack too. Bang, the study was stopped. Altogether, there are about 27,000 women in these studies. These were huge studies, costs, millions and millions and millions of dollars.
So all of the women would have come off of hormone replacement at that time?
So they would out of the study. What women then chose to do in their personal lives was different. Now, the study was geared to see if women at an average age of 63 years at the beginning of the study would have less heart disease if they were given estrogen. That's not the average age of menopause. So the women were recruited into the study if they were aged 50 to 79.
So many of those are perimenopause.
Very few of them were perimenopause.
Oh, very few are peri.
This study tells you nothing about women who went through menopause before the age of 50.
Mm-hmm.
You had to be 50 to get into the study. And the average age of women in the study was 63.
Mm-hmm.
So, on average, women were at least 13 years post-menopause, at least.
Mm-hmm. Okay, so intervening pretty late.
So it was a late intervention study. And their headlines in the newspaper when the first paper came out was HRT causes breast cancer across the world. And of course, everybody panicked. As a consequence of this study, HRT just went off the radar. People stopped prescribing.
Did they look at other outcomes? I thought they also looked
They looked at other outcomes. There was clear evidence that there was a massive reduction in osteoporosis and fracture. Even in women who did not have osteoporosis, the fracture rate was reduced. It's the only medication ever shown to dramatically reduce fracture rates in women without osteoporosis. There was an increased risk of thrombosis, deep vein thrombosis, which occurred mostly in the first 18 months of use. And this is what we know happens with estrogen tablets. You don't tend to see it with estrogen patches or gels. For women aged 50 to 59 who went in the study, there was no increased risk of cardiovascular disease. There was a small increased risk of stroke in some of the greater age groups. For women who got estrogen only, so the estrogen plus progestin study, BAM, closed 5 years. The other one's still going, estrogen only. That stopped at 7 years. When they stopped that, the women who got estrogen only had a lower risk, borderline low risk of breast cancer compared to women who got placebo.
Yeah, I think I saw that summarized in the NAMS position statement. Is that a good position statement?
Yeah, the NAMS one's quite good.
Right.
So now we've got one study showing estrogen progestin may cause breast cancer.
Increasing risk, yeah.
Another study showing that if you had a hysterectomy and take estrogen, you've got possibly a low risk of breast cancer. What's really important is the 20-year follow-up of these studies. 20 years out from these studies, it shows that overall there is no difference in all-cause death or death from any specific cause such as cancer, heart disease, breast cancer, except there appears to be possibly a lower rate of death from Alzheimer's disease.
Fascinating.
But you wouldn't say that we're talking about statistical significance. You've got to treat thousands of people to maybe see one difference. But what this is telling us is 20 years down the track from the Women's Health Initiative study that involved women taking either estrogen only for an average of 7 years or estrogen plus progesterone for an average of 5 years, 20 years down the track, you weren't more likely to die from pretty well anything, whatever you did. So does HRT kill you? No. Does it save you? No. If you've got symptoms, should you take it? Probably.
Is it this data where the recommendations come to the sort of advice to take HRT within 10 years of menopause? Why 10 years?
So the initial WHI data comes out. studies are being published at a rate that you can't even keep up with what's coming out and being published. Analysis after analysis after analysis. And then the later analysis shows, we shouldn't have worried so much in the beginning, but everyone worried in the beginning. So it's very hard to take a bad thought out of people's brains.
Once it's hit mainstream media, tough to undo that.
Yeah, it's very hard to unpick. And people didn't know what to do. So what do? You come up with some reassuring consensus. Why don't we tell women that, well, in the WHI study, it didn't seem to have any ill effects in women who were aged 50 to 59 when they started HRT or within 10 years of menopause. What we'll do is we'll tell women, we'll put in a consensus, we'll feel pretty safe. You can take HRT if you're within 10 years of menopause or age less than 60. Now, I've still never got my head around this one, because what happens if you go through menopause at 55 and then you're 61? You're not between the age of 50 and 60, but you're within 10 years of menopause. Where does that put you? I don't think anyone's ever really worked this out. And that's stuck because everybody felt safe. The experts.
What's your view on?
There's no evidence base for that guideline. Mm-hmm. And the experts, it made the experts feel safe. It made the community feel safe. We all like to feel safe. We now recommend that each individual has to look at their risks and potential gains. And in general, taking that into account, hormone replacement therapy can be taken for as long as there's a reason to take it. Now, for some women, it's protection against bone loss and fracture. For other women, every time they stop it, at the age of 66, 67, 71, they miss a few tablets or patches, they just can't function with the symptoms. You have the conversation, and they may continue to take it at a modified dose, as a patch, not a tablet, whatever.
You mentioned dementia before, but acutely is brain fog, like fuzziness, is that another clarity, lack of clarity, is that another symptom?
Brain fog is a symptom everyone talks about, and it's very difficult to separate it from hot flushes, estrogen, and sleep deprivation. If you don't sleep, you don't function. Anyone who's had a period of stress and bad sleep will know you have brain fog. The combined studies at the moment show that women during the perimenopause and the early menopause have reduced what we call verbal fluency, so you can't remember words. That actually seems to recover over time, even without HRT. Whether women adapt, whether sleep improves, whatever. But the evidence that HRT improves cognitive function is lacking.
Okay. Well, academics out there, there's an area to research.
It's a really important area.
Mm-hmm. So the breast cancer risk, let's just double click on that. And I think that's something a lot of people are interested in. Usually I hear about breast cancer risk, blood clots, or cardiovascular disease risk when people are talking about HRT. But I think breast cancer risk probably gets the most attention. So I've got a couple of questions here. One is, what is that risk in terms of like absolute terms, if we're trying to quantify that, maybe relative to having a glass of wine or being overweight? Is
the risk is worse if you're overweight or obese.
Right.
If you're overweight, this is from UK analysis of old studies, but if you're overweight, Val Beryl, who is a famous epidemiologist, sadly recently passed on, her data shows that overweight is associated with a 20% on average increase in breast cancer risk and obesity of 40%. The worst case scenario of traditional estrogen plus progesterone tablets, common garden variety, the increased risk is about 30%. So somewhere between overweight and obese.
What about a woman who has a history of breast cancer?
We do not treat women with past breast cancer with hormone therapy. It is close to as you will get for an absolute contraindication. There are very, very rare examples where in consultation with the treating cancer specialists and the patient that the symptoms of her menopause are so dire that we will treat with estrogen, but that's the absolute exception.
Quick one, folks. I get asked all the time about buying supplements and getting blood tests. The good news is I've created comprehensive and completely free guides for both. Simply head over to my website, theproof.com, to download them. That's theproof.com. Okay, let's get back to the episode. Let's first take the example of a woman who commences HRT at, say, 51 and a half.
Okay.
She's just entered the postmenopausal period of her life. The most common question I got from that woman was,
How long?
I'm on HRT, yes. How long do I continue to take it? Do I take it for 10 years and then I can assume that if I come off, I won't have these acute vasomotor symptoms? Or should I just continue it to get the possible benefits for risk reduction for osteoporosis, for example?
Okay, so the how long is the easiest question. Every major guideline now in the world says as long as there are still individual treatment goals and that each patient has regular review of the benefits versus the risks. So if you've got a woman with low bone density, or if you don't have a bone density machine and you're in a less developed country, very skinny woman, you are going to be protecting her against bone loss, and you might choose to continue for longer. But there's no cutoff at 5 years or line in the sand at 10 years or even at 20 years. And there'll be women who will forget to take their tablet or put on their patch or their gel for a few days, and they'll have no difference in their symptoms. They feel fine and they know they can stop. And there'll be other women that, well, they say to me, oh no, I never forget a tablet or a patch because if I do, the symptoms are horrendous. Well, they continue and we might gradually lower the dose. So it's individualized. There's no line in the sand.
So if there's no family history of, say, osteoporosis, and if they were to go and do like a DEXA and their T-score was normal, then that's someone that you would be happy sort of coming off of the HRT.
Yeah, I don't get too strung out about family history of osteoporosis either because our parents' generation didn't have the nutrition and the health that we have. So I think it's the personal history of fracture, other health conditions, risk factors for osteoporosis. And if you are able to do a bone density, not everyone can, then you would take that into account as well.
Okay, that's clear. The other scenario. So a woman is aged 62. She's a little more over 10 years from menopause for her. What does she need to consider with regards to whether she can commence HRT?
Okay. Well, the thing about this that's confusing is that guidelines that keep popping up are less than 60 or within 10 years of menopause. So if our 62-year-old lady went through menopause at 55, she's within 10 years of menopause.
Let's say that
So the guidelines are pretty sort of messed up, really. But if she went through menopause at 51, she's got horrible symptoms, I'd still treat her. Taking into account, though, other risk factors. So if she had uncontrolled hypertension, I'd treat that first. I would look at other health components, but I would still treat that person because she needs treatment. I would use the most conservative therapy available to me, but I'm still going to relieve. If she's waking up 3 times at night drenched in sweat, I'm going to treat her.
You alluded, or not alluded, you made it very clear that the formulation in the Women's Health Initiative is different to what you would mostly prescribe today. Perhaps you could just comment on sort of how your views have changed over the years with regards to your preference for the form and or dose of HRT. Has much changed over the last sort of 20, 30 years for you?
I think perhaps the greatest thing that's changed for me is that we get hung up on And I learned a lot about this from research because I get to see data that other people don't get to see. So let's take it, to simplify it, let's look at the estrogen patches. There's a The doses are 25, 37.5, 50, 75, and 100 micrograms. We've got 5 doses. Why is it that some people can put on a 25 patch and get fluid retention and sore breasts, but their hot flushes have gone, and other women put on a 100 patch, they have no side effect and they've still got some hot flushes? And there are several reasons behind that. One, the absorption varies between women. So some women with a 25 patch can get a higher blood level than someone with a 100 patch. 2, the blood levels aren't the be-all and end-all. I might need a higher blood level to activate my receptors than another woman. So
because they might be less sensitive.
Yeah, my tissues might be less sensitive. My brain tissue, my bone tissue might be less sensitive. So we can't assume that higher doses are necessarily bad and we've got to get this person on a lower dose. Oh, I don't want to take this big dose. Well, if you're on a 50 patch and it's not working, but a 75 patch does, it's really that biologically you're different. And the analogy would be, in the middle of a menstrual cycle at ovulation, some women ovulate with an estrogen level of 500 and other people ovulate with an estrogen level of 1800, so more than 3 times. So our bodies are all different because our tissues have different sensitivities. So I think the greatest thing I've learned is not to get hung up about dose and manage each individual person.
And I should have mentioned in the summary, the goal of hormone replacement therapy, we made clear in the last episode, is not to restore the levels of hormones that a woman would have during her reproductive years, but to get a certain blood level that helps reduce symptoms primarily.
Yes, and the blood, we don't measure blood, we don't treat to a blood level, because what will alleviate one woman's symptoms may be either not enough or too much for another woman. But when it comes to bone, you don't need very much estrogen to protect bone.
You mentioned estrogen receptors in the brain. How does low estrogen affect brain health, cognition? Do we understand that?
No. So it's sort of also interesting that there's this real cry from women that the main thing that's bothering them is their cognitive function. This seems to be a new thing in a way because most women tended to be worried about flushes a few years ago. During the perimenopause, when the hormones are going up and down, is the time where women are most likely to experience awareness of changes in their brain functioning. And most of this is word finding, short-term memory, and concentration. But it tends to improve as women go past the perimenopause. So if nothing's done, it does tend to naturally improve. So it may just be reflecting the chaos of the hormones, not absolute blood levels, because after menopause, the levels are very low. The other thing is that we assume it's directly due to estrogen in the brain and brain cells functioning and networks in the brain functioning. But what also is happening at this time is terrible sleep. And poor quality sleep is one of the greatest risk factors for dementia. I'm not saying everyone at menopause is going to suddenly get dementia, but I'm saying is that if any individual reflects on a time in their life where they haven't slept well, your brain doesn't work very well the next day. If you've had a period of stress and poor sleep, it's shocking for brain function.
But what causes the poor sleep?
Often hot flushes.
Right, but what's causing the hot flushes?
The chaotic estrogen.
Right.
But it may be, the mechanism may not be a direct effect on the brain, maybe indirect through poor quality sleep. And it's fascinating that giving HRT does not objectively improve measures of cognition.
I want to come back to indirect and direct when we talk about weight gain, because I think there's some relevance there as well.
But if you look at any study that has looked at hormone replacement therapy and cognitive function, the big studies, you do not see an improvement in cognitive function with HRT.
Short-term cognitive function.
Any domain of cognitive function.
Do we have any data on, say, women who have had breast cancer and have had pharmacotherapy to lower estrogen, whether they're at increased risk for dementia?
That's complicated. In fact, we almost got an NIH study, a study funded by the US to do that. The problem you've got is controlling for the stress of having had breast cancer and chemotherapy. Because chemotherapy, you get chemo brain. And so there's chemo brain's been well established.
What's that?
So after chemotherapy, people, not just women, will experience change in cognitive function. It diminishes,
Is that because it's just indiscriminatory in its action and it's affecting neurons?
Well, again, is it related to suppression of there's so many mechanisms. The inflammation that you might get after chemo, it could be direct effects on the brain. It could be, chemo's poison cell. There are a whole range of things, but is it just the exhaustion, the fatigue? Who knows? But it's well described. So teasing out whether lowering estrogen after breast cancer impairs cognitive function. Some women complain terribly of it and other women say, I feel fine. Very hard.
Is there anything that you've used clinically or any advice you've given to a woman who has been struggling with cognition that has been of benefit?
Oh, getting sleep and less stress. And yes, if you treat the hot flushes and night sweats, women do tend to improve quite a lot. Women will come and say, I can think again, I've got my life back. But is it directly estrogen effects? People talk about menopause alters brain structure. I think it's still unclear.
Right. Sleep deprivation has a knock-on effect of many things. It could
everything.
Affect the type of food you eat, how much exercise you do.
Exactly.
How social you are.
Yeah, it's complicated.
Yeah. The lady who connected you and I won't mention her name, but she's a friend of mine, a sort of professional colleague that's helped me professionally over decades now at this point. She actually entered early menopause. So in her 30s, her period stopped. And I did have a number of questions about early menopause that came through. So perhaps we can dig into that a little bit, starting with, from a definition point of view, what is early menopause?
So the definitions are very much for people of European ancestry who go through menopause at an average age of 50. I say that because if you live in India, the average age of menopause is 47. So obviously early menopause, 45 is not early menopause. So people of European ancestry, by definition, premature ovarian insufficiency, which used to be called premature menopause, is before the age of 40. And early menopause is from the age of 40 to 45.
Got you, because those two terms are sometimes conflated.
Yes. So early menopause is, strictly speaking, between the ages of 40 and less than 45. And premature menopause or premature ovarian insufficiency, we often call it POI, I'm going to sneeze in a minute, is before the age of 40.
And with premature ovarian insufficiency, am I right that there is a primary and a secondary version of that?
So the language gets really messy because primary is usually referring to having never menstruated ever. So there are some girls with genetic abnormalities that will never menstruate. And secondary is you've menstruated, but then your ovaries stop functioning. Or you can use it in terms of primary, it's an ovarian disorder, and secondary, it's induced by chemotherapy or radiation therapy. So the language is often very messy. And in the end, you can have a genetic disorder like young women with Turner syndrome, where they've got genetic disorder and their ovaries stop working. Some of those young women never menstruate, and some have a couple of menstruations and then never menstruate again. So sometimes the definition's not really that helpful.
I had a comment come in from a lady said, I was told by my doctor my symptoms cannot be perimenopause as I'm 42. Is this true?
That's complete nonsense. I mean, of course. I mean, she could have early menopause.
So what could cause a woman to have premature ovarian insufficiency and her period to stop in her 30s, and what could cause early menopause?
Well, again, we put this line in the sand of 40, but really is a 39-year-old very different to a 41-year-old? So, although we say menopause before the age of 40 is this thing and after is that thing, it's a bit of
all kind of one bucket.
Yeah, it's a bit of a moving feast. So let's just call it early menopause. The majority of cases have normal genetics and no cause is ever identified. Normal genetics to what we can measure. But very frequently there's a positive family history of a person's mother going through an early menopause or a sister going through an early menopause. So it's something familial, but we can't identify it. Then it sort of just breaks down in sort of equal groups of about 10% are associated with autoimmune disease. So someone who's got thyroid disease, adrenal insufficiency, some other autoimmune disease in the family, diabetes, rheumatoid arthritis, etc. And so it's an autoimmune cause affecting the ovaries. So we always check for thyroid function, etc., in young women with early ovarian failure. There are genetic causes. I mentioned Turner syndrome, and there are other genetic causes, but the most common is actually Fragile X gene mutation. This is a genetic mutation that progresses through generations. So it becomes amplified through. So if I've got a few changes and then I have a child, they might have some more changes with no clinical features. Then they have a child and the gene changes over time.
As in progressively greater and greater chance of premature ovarian insufficiency.
Well, so it's once you get these genetic code repeats, and the number of repeats increase and increase and increase. So normal's less than 44, say. And once you get between 44 and 200, then of repeats, it's just like going blah, 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 blah repeatedly in the gene. That once you get all these repeats in the genetic code, it's called the premutation, and that's associated with early menopause. And then once you get the full-blown mutation, you start to see autism. It's one of the most common genetic causes of autism.
So if someone has that, more reason where possible, where in someone's control to have kids earlier rather than later?
Having kids early, well, they need to be, if someone has that genetic mutation, they also need to be aware that they could potentially have a child with autism. It's perhaps the more important thing. And so that's where knowing what risks there are and family history is critical to decision-making about fertility.
If someone has premature ovarian insufficiency, and I understand you've just outlined there's a number of different potential causes, so this could vary case by case. Once someone's diagnosed with that, is there still the chance that they can conceive?
So we didn't talk about radiation therapy, chemotherapy, and a lot of people are surviving childhood cancers now. So that's an increasing number. So putting the medically induced early ovarian failure aside, the chemotherapy.
Does a hysterectomy fall into that as well?
No, you have to have your ovaries removed, not just your uterus. Mm-hmm. I mean, you can't get pregnant if you haven't got a uterus, but if you need your ovaries removed to surgical menopause. So of what we call spontaneous premature ovarian insufficiency, so no clear genetic mutation, not medically induced by drugs or radiation, etc. Of women with spontaneous premature ovarian insufficiency, about 15% can conceive. So we never say to those women, you are absolutely infertile, and that's why we don't put those women on the pill to give them hormone therapy, because if they want to conceive, obviously if they're on the pill, they're not going to conceive. So the likelihood of getting pregnant is remote, but not impossible.
Does it ever have to do with the pituitary gland and like LH and FSH?
So the ovaries are controlled by the brain. the most central part's called the hypothalamus, which is right in the center of the brain. And that sends messages to the pituitary, which makes hormones, FSH and LH, which then stimulate the ovaries. The ovaries make hormones. The hormones feed back onto the brain and tell the brain, hey, we're working. So you can get abnormalities in the production of FSH and LH from pituitary tumors. But things like if you're making too much of the hormone prolactin that causes breast milk in breastfeeding, that'll stop you menstruating and ovulating, but that's reversible. So it's not premature ovarian insufficiency. But there are some times where the brain is not making these hormones from birth. One of them is called Kalman syndrome. And in that setting, women have a brain cause of their ovaries not working, but they can still get pregnant because we can stimulate their ovaries.
Mm-hmm. Okay. So to recap, though, if a woman is in her 30s or early 40s and notices irregularities in periods, is that the key sign?
Very simple. 6 months of not having a period should be investigated. And that's because there are multiple reasons for that, not just early menopause, that range from overproducing prolactin in the pituitary through to early menopause, through to stress-induced not having periods. And so the rule of thumb, no spontaneous periods for 6 months and not on the pill, obviously, or not with hormonal contraception, you would investigate.
Do you know if someone has had relative energy deficiency syndrome, experienced that, and had amenorrhea? Let's say
Had which? Sorry?
REDS. I sent you
Yeah.
that I think I sent you maybe, I'm not sure if I sent a paper.
It's the exercise-induced.
Yeah, so exercise-induced sort of energy deficiency.
Yeah.
Typical kind of avatar here is a woman in her 20s or early 30s. She's overtraining, training the house down, undernourishing, and she notices that she's lost her period. So she experiences amenorrhea. If a woman has experienced amenorrhea in her 20s, is she at increased risk of early menopause?
No. But can I just correct that? That picture's often painted. So some girl turns up with not having had a period for 6 or 8 months. And this young woman is 28. She's not exercising ridiculously. She's not underweight. She's normal body weight even. She's not anorexic, but maybe really controls a bit what she eats. But they actually have the same brain changes of the RED syndrome, the girl, the extreme version. Because we keep looking for the extreme version. All you need is chronic subliminal stress and your periods will switch off. So a lot of young, healthy girls who just have this, we used to call it a type A personality, perfectionist, worry a bit about things, maybe a bit under the pump at work, exercising but not crazy. I mean, the exercise might be yoga 3 times a week and Pilates and take the dog for a walk. But a lot of these are missed because people don't realize they have the same chronic low dose stress that is feeding onto the central part of their brain that controls their cycle, and the brain goes, shut it down. So
in that scenario, to help the period resume is to look at what is causing the stress, what's
causing the stress. And if you look at young women with anorexia nervosa, their periods stop well before they lose a lot of weight.
Mm-hmm.
It's not the weight loss, it's the stress.
Mm-hmm.
And so this is often underappreciated. And what we often see is many of these young women are misdiagnosed as having polycystic ovary syndrome, PCOS,
Mm-hmm.
because if you scan their ovaries, they have lots of little follicles in their ovaries because they're not ovulating and they're all accumulating. So often these women are misdiagnosed, told they had PCOS, look it up. Oh my God, I'm infertile. I'm going to get diabetes. I'm going to get heart disease. And I'm going to get fat. Then they go crazier because they're so stressed now.
So what would be like the telltale kind of signs or symptoms or tests that would differentiate and help you determine that, okay, it's not PCOS here?
Their hormone profile looks pretty normal. And one absolutely telltale sign for me is a very unexpected thing in the blood called sex hormone binding globulin. This is a protein that circulates in men and women, made by the liver, and it transports hormones in the bloodstream. It's like the train and carries the hormones around the bloodstream. Women with PCOS nearly always have low SHBG. The SHBG is not low, and someone hasn't had a period for a few months, and everything else looks a bit normal, they're very unlikely to have PCOS.
Do women with PCOS, do they experience menopause later? Is it pushed back?
No.
No. Does their experience of menopause, is it likely that it will differ from a woman without PCOS with regards to symptoms, severity?
Not really.
Okay.
No. And in fact, PCOS used to be considered the harbinger of heart disease in later life. And Bart Fauser, who's one of the world experts in this, has shown that after menopause, women with PCOS are not more likely to have heart disease than other women. So it's not as evil as people think, having PCOS.
I'm sure that's comforting news for a lot of people. Back to early menopause. Something else that I've read online, and I think maybe a few people sent me a question about this, was when a woman enters early menopause, I believe her risk of breast cancer is actually lower than if she hadn't entered early menopause. But that changes a little bit if she was to commence hormone replacement therapy. And I read an article that you posted that provided some nice context for someone who's kind of interested in that.
One of the risk factors for breast cancer is a late menopause, because your breasts have got more and more and more years of being exposed to estrogen and the changes through the month. So if a woman goes through premature early menopause, compared to all the other women in the street of the same age, her risk of breast cancer is reduced compared to them. If she goes on hormone replacement therapy, we will not give back nearly as much estrogen as she would have had as if she'd never gone through early menopause. So you're not increasing her risk like you might be potentially increasing the risk of a 60-year-old taking hormone replacement therapy. You're just normalizing her. So it's just like if you've got an underactive thyroid, you take thyroid hormone to bring you back to baseline. But we don't even bring women back to baseline risk of breast cancer with HRT.
If a woman does enter early menopause and say is untreated and has exposure to low estrogen, it's longer than someone who would enter menopause later. So just to be clear here, and I guess this speaks to the importance of diagnosing early menopause and thinking about treatment options, does she have increased risk of osteoporosis and cognitive decline and cardiovascular disease?
So consistently, studies have shown that menopause before the age of 45, untreated, is associated with an increased likelihood of osteoporosis and fragility fracture early in life, heart disease early in life, and premature death. And as much as we bag the WHI study, that study showed that women who are women who had their ovaries out before the age of 45, who are now over 50 to go in the study, who are allocated to estrogen therapy versus placebo, had, I think it was like a 40% less likelihood of death in the follow-up. So estrogen protects women who go through early menopause, and unless a woman has a contraindication like breast cancer, I don't think there's anyone who would not say if a woman goes through menopause before 45 that they should have estrogen. They really should. It protects them.
Are there any other contraindications other than breast cancer?
Breast cancer or hormone-dependent cancer, that's not managed would be the main ones. I mean, endometrial cancer, uterine cancer is a hormone-dependent cancer. So clearly it would depend on the stage it was diagnosed. If it was diagnosed extremely early, woman had a uterus removed, she had a curative procedure, you would still use hormones. So breast cancer is the big one.
What's the role or potential role, and I think one of your clinical trials may be looking at this, for testosterone for women that have entered early menopause?
Testosterone, we know, can be extremely beneficial for postmenopausal women over the age of 40 in terms of improving libido.
And that's from clinical trials.
Clinical trials consistently have shown that, large clinical trials. Where we completely lack evidence is, are there any other benefits? Because all the studies looking at bone and muscle and heart disease are too small and too short. So presently, we're recruiting women to a study who are under 55, have gone through menopause, are on estrogen, and we're going to look at testosterone versus placebo to look at their bone health, and we'll look at sexual function and muscle function as well. And then the other group where there's a lot of interest is, does testosterone improve muscle function, strength, muscle mass in postmenopausal women? So we're also doing a study looking at women over 55.
Why is that important? Can you remind us of?
So muscle's really important because particularly as you get older, because not only do muscles stop you falling over and stop you fracturing, but as we age, from the age of about 55 onwards, our muscles get infiltrated by fat. And when that happens, when you get, you know what a fatty steak looks like compared to a lean steak. And when it gets infiltrated by fat, we become more insulin resistant, and that's the pathway to type 2 diabetes. So keeping muscles fit and strong and healthy actually protects you against type 2 diabetes, which then protects you against and other diseases like heart disease. So we're looking at whether testosterone has benefits on muscle compared to placebo in women over 55. So we're doing those two major studies, which will tell us a lot about muscle and bone in younger postmenopausal women and older postmenopausal women.
And that's in women presumably that are just going about their everyday life, or are they doing specific exercise? Or
no, we just want all comers.
And outside of all of this, a woman sitting down with you and she says, from a lifestyle point of view, and I think you kind of broadly mentioned nutrition, exercise, but are there any specifics that you would give her and say, look, these are the biggest levers that you can pull if you're going to focus on a couple of things?
This is after breast cancer.
This is a woman, let's just say any woman, who is interested in lifestyle changes that can improve her bone mineral density.
Oh, improving bone mineral density, multimodal exercise. So walking the dog is not exercise. I mean, it's sort of exercise, but it depends on the dog. If you're jogging with your dog, that's exercise. Strolling around the park with your dog's not exercise. Putting on your lycra and going for a leisurely walk with your girlfriend is exactly that. Unless you're hot and sweaty, it's not exercise. And it's not and walking doesn't really help your bones. Walking's just a good thing to do. To get your cardiovascular system going, you've got to get a bit hot and sweaty. And to help your bones, you've got to do something that involves a range of different movements. So that's what we call multimodal. Involves weights, involves hopping, skipping, and jumping. So bounding up and down, Tigger exercises, or a combination of these. And that will help bones. But unless you're doing that really regularly, all you're doing is doing something nice.
Yeah, my mum is actually in a clinical trial at the moment. She won't mind me mentioning this, with Deakin University, looking at a multimodal exercise program versus a kind of standard care approach.
Yep.
So
probably Robin Daly's thing.
Yeah. So it's good that people are kind of studying that to see what is the effect on bone mineral density.
Very important.
Let's slide over to questions that I got about other symptoms. And this one actually came through a few times. Is it true that shorter menstrual cycles in a woman's reproductive years is associated with more severe menopausal symptoms later in life.
It's a new one on me.
Okay. We'll put that one down to social media. And then there was a follow-up question. Is this the same for an intrauterine device?
No.
Okay. As in,
It's got
there's
nothing
no
to do
increase
with
in risk.
the intrauterine devices release, well, some are non-hormonal and just sit there and are mechanical in their effects. And other ones release hormones into the uterus to stop implantation of an egg. And they don't do anything to the ovaries. The ovaries just tick along as normal.
Right. So either of these scenarios, there's no evidence to suggest it's going to affect menopausal symptoms or timing of menopause, etc. Question. Why do we get night sweats? What's causing that?
How long do you want me to take to answer this question? There are cells in the brain called there are cells in the brain called Kindy neurons. And they're called that because they release a range of hormones or chemical messages, kisspeptin, neurokinin, and dynorphin. Neurokinin I mentioned before with a new medication that's been developed to block hot flushes. And kisspeptin is actually one of the central chemical messengers that controls the onset of puberty and the ovulatory cycle, as well as what happens at menopause in terms of hot flushes. And these nerve cells at menopause actually get bigger. And it seems they maybe become more active, and more neurokinin 3B is released, and that goes down a pathway that activates the thermoregulatory center in the brain. And in that center, when you get this change in these nerve cells, more of this neurokinin 3B being released, triggering hot flushes in some pulsatile way. Why exactly does this happen? We don't know. There are all sorts of diagrams that we draw and clever hypotheses we make and studies done in rats looking at the temperature of the rat's tail, but we don't really know exactly. And why do some women have a hot flush response after menopause and others don't? And why do some women have terrible hot flushes for 6 months or 12 months or 2 years, then they go away, if nothing else has changed?
So there's no patterns whereby, say, women who are exercising less or eating a less healthy diet or are more overweight have worse?
Women are at a greater increased risk of hot flushes and night sweats if they're overweight or obese. And exercise doesn't seem to come into the equation. If they're smokers, they're the most common, the greatest links we can see.
Okay. And so you mentioned, what was the name of that drug before that you mentioned?
Oh, the neurokinin 3B antagonists.
Okay, got you. And is there an actual sort of brand name?
Oh, Fesolantant.
Got you.
Is the one that's under review.
Mm-hmm.
There have a number have been developed that have not progressed because they've ended up with unwanted side effects, and several are in development. But being mindful that all they do is reduce the hot flushes, night sweats, and improve sleep as a consequence, but they don't do anything for mood changes, anxiety, vaginal dryness. So they're not an estrogen. They're just acting on the hot flush center.
And estrogen, though, just to kind of re-emphasize something, can also reduce these night sweats.
So estrogen feeds back onto these cells that, let's say, go rogue after menopause and calms them down, and therefore you get reduction of hot flushes and night sweats.
This is perhaps one of the symptoms where the complementary medicines, alternative wellness space pops up. Are there any complementary medicines, herbs, alternative options here that have proven safety and efficacy for night sweats, hot flushes?
So we've just reviewed all the international guidelines, and there's agreement that phytoestrogens are not helpful. There's agreement that the majority of things that have been tried are not helpful. Acupuncture in placebo-controlled trials has not been helpful. Yoga is not helpful. Black cohosh is considered unhelpful and helpful by different recommendations. With black cohosh, there's a huge, for all of these things, there's a big placebo effect. Black cohosh appears to be perhaps a bit helpful for women with not very bad symptoms. So it's been shown to maybe have a benefit in women with very few hot flashes, mild symptoms. But if you've got raging hot flashes, night sweats, no. Cognitive behavior therapy has been shown to help women cope with the events. So when they start to get the hot flush, getting less overwhelmed, dealing with it better. But basically, no. You wouldn't want to spend your money on most of these things.
Right. So soy isoflavones and soy foods. Because I think I've seen a couple studies, but is it just that there's not enough evidence?
No. Quality of studies have shown no benefit. The really good studies show no benefit.
Okay. That's interesting. I think that'll be news to some people who have heard otherwise.
It was all a rage in the 90s, and we did all these studies and we showed no benefit. Other people showed no benefit.
Is that with phytoestrogen isoflavone supplements or soy foods themselves?
Both.
Let's double click on weight gain. And we spoke about this previously. We spoke about the fact that fat cells, particularly around the abdomen, can produce a little bit of estrogen. So there's perhaps this physiological change during menopause where the body's trying to hold on to some of that as the ovarian function declines and there's less estrogen produced there. And I was reading one of your papers on weight gain. I think was that 2012 or 2013?
Weight gain at menopause.
Yeah, sometime around then. And you kind of really nicely pointed out that certainly fat distribution seems to be able to trace back at least partly to changes in hormones and menopause, but sort of total body weight perhaps not. So can we kind of explore that area and provide us a bit of a synopsis, I guess, as to what you found when you wrote that review?
So studies, doesn't matter what country they're done in, show that on average women increase their intra-abdominal fat by 20 to 40% through menopause, even if their weight doesn't change. So we shift weight to our bellies.
Which is a problem because that's the more sort of metabolic damaging
That's the bad
type
fat.
of fat.
That's the unhealthy fat. But really well done studies that have followed women every year with body composition measurements. The SWAN study, the Penn Aging study, and other studies have shown that the weight gain women complain most about menopause is actually an age-related weight gain creep that starts around later reproductive years and is not due to menopause per se. It's an age-related creep.
As in, it's not specifically due to this change in hormone level.
It's not due to change in hormones.
Right. So then what do we understand what is causing that creep?
Mostly lifestyle.
Mm-hmm.
And I guess what exactly, we don't know exactly. What do I hypothesize? Your life changes. You know, the average 54-year-old woman is not running around after a 3-year-old or even a 12, some still are running around after 12 and 14-year-olds, but the majority of us who have had children, the kids can look after themselves by the time we're going through menopause. And it's about lifestyle. It's about being less active. A lot of it's about being less active, bad food. Look at the population. So we studied 7,000 women aged 18 to 39 in Australia. They're representative of the Australian population. 45% are overweight or obese, aged 18 to 39-year-old women. Fast forward 10 years, what are they going to be, And so it is a whole societal health issue. It's an age-related weight gain creep that occurs. And as we get older, our metabolism slows. So there's so many reasons. It's mostly not menopause.
Do women that come in to see you clinically find that hard to believe? Because I think, the common sort of question or comment that I get is nothing's changed. I'm eating the same.
But it has changed. Firstly, you're older. And as we get older, our metabolism is different. And secondly, I think our lifestyle's changed. I mean, gosh, I've got a car that I just go near it and I can open it. I don't even have to lift our lives have changed.
But it's not just about accepting it, because what I'm hearing from you is that there are things that a woman could do to reduce visceral fat and some of those changes.
I saw a patient about a year ago. She came in, she said, well, I need to tell you, Dr. Davis, I wasn't going to come back to this appointment. I said, oh, really? Yes, I wasn't coming back. In fact, I was horrified. I left and didn't want to pay the bill, and I went and spoke to my own doctor. I said, oh, I'm really sorry if I upset you. She said, yes, because you told me I was overweight. You told me I needed to lose some weight. I actually felt quite good when I came in here. And I said, oh. And she said, and I've lost 8 kilos and I feel fantastic. Because I went to my doctor and my doctor said, well, I didn't want to say that to you, but, Dr. Davis is right. And I mean, she wasn't obese. She was overweight. And she said, I did lose the weight and it wasn't that hard. But it's not politically correct to tell somebody they're overweight. I mean, you asked me, we talk about hormones and breast cancer. Women who are overweight have a 20% increased risk of breast cancer. And if they're obese, it's 40% increased risk. Hormone therapy doesn't increase. The worst outcome study hasn't shown a 40% increased risk. So
puts it into perspective.
Yeah, and it is not healthy. As a society, we are overweight and obese.
So how do you feel about talking about being overweight, being politically incorrect, and what's the way of kind of navigating that and
I think it's
moving
acknowledging
forward?
It is not healthy to be overweight or obese. And I think that, and I say to patients, don't go on some crazy diet.
So what about the person who pushes back and says, well, Dr. Davis, I've heard that you can be obese and be metabolically healthy.
There was this sort of trend for the metabolically healthy obese person. That's all gone out the window. It's been disproven. It's not metabolically healthy to be overweight or obese. And listen, believe me, I don't think it's easy to be, I'm not saying everyone should suddenly be skinny, okay? We have sociocultural factors that discriminate against people having the opportunity to be as healthy as they want to be.
Sure.
You're a single mother with 3 kids. You got to get up. You go and work in a call center all day. You get home and it's dark. You start cooking dinner. What hope if
you have time to cook?
Yeah,
could just be takeaway.
And you probably just buy the cheapest thing you can buy.
Mm-hmm.
Okay, so it's not easy, and I think it's a community issue. It's not an individual issue. That's why I say 45% of young women are overweight and obese. No one's being bad. No one's exhibiting bad behavior. We have to do it better as a community.
Yeah. So you're not saying to blame the individual.
There is
you're
no
just saying
blame.
We shouldn't sweep this under the carpet.
We should talk about it and say, we got rid of smoking pretty well. That was a community effort. What can we do to make healthy foods more available? What can we do to make physical activity more available to people? And I think it's not an individual blame thing by any means. I wouldn't like anyone to interpret me as saying that.
Yeah, I think some of that metabolically healthy overweight research was misrepresented, because it is true that you could have 2 people who are both overweight, but one has more visceral fat and perhaps has higher risk. But that's not to say the other person would not be lower risk if they lost some weight.
Exactly.
Okay. So if a woman is listening to this and saying, okay, this is great, I realize that I need to lose some weight. We spoke last episode about estrogen therapy perhaps having an effect on visceral fat. Is that right?
Potentially, yeah.
Potentially. So it could reduce some of that sort of change in fat distribution. What else? What are the main things that a woman can focus on who is thinking, my life really hasn't changed that much, but I would love to lose some weight?
I think a couple of things. Being physically active obviously is important, but you have to jog for 20 minutes to burn off a glass of orange juice. You have to do a lot of exercise. Most people can't really do enough exercise that will really burn the calories. So it's really being very honest about what you put in your mouth and just changing a couple of small things. 30 years ago, we weren't drinking a couple of lattes during the day. We were just adding a bit of milk to our coffee. You have a long black coffee with a bit of milk in it. Now we have a little bit of black coffee with a lot of milk in it. Small things like that. Just changing. I just suggest people identify a couple of small things they can change and gradually drop some weight, not try to lose weight in a big hurry.
There's a big conversation right now, particularly in the States, around semaglutide, this GLP-1 agonist for people that really are struggling to lose weight and perhaps have an appetite that they can't curb. Do you see a role for those types of drugs to help people lose weight?
I definitely see a very clear role for the new weight loss drugs that were originally developed for treating diabetes. They can be incredibly beneficial. But for someone who's like 5 or 6 or 8 or 10 kilos overweight, they're much better off to change their diet and exercise a bit more to lose weight, because when you do it that way, you keep it off. The problem with the injectables or the SGLT2s, etc., is that I've seen people lose, say, 5 or 10 kilograms on them and they stop the medication, they gain the weight again. Well, if you're only 5 to 10 kilos over, you're probably better to just lose it naturally. For people who have become extremely overweight, they're just a godsend, because you can get to the point that you just don't know where to start to lose the weight. And the confidence building this can give people, and that they can actually control their lives, is amazing. So I think they're great drugs, used appropriately.
Let's talk about Naomi, 60-year-old woman, post-menopause, and we can, I think, bring in perimenopause into this conversation as well. I appreciate there's probably listeners who are interested in that phase as well. But Naomi is 60 years old, and she has low bone mineral density. Okay. Now, she's not taking HRT, and the reason for that is she has a history of breast cancer and was told it's contraindicated. Now, she's gained a little bit of weight around the midsection despite doing regular exercise, and is eating sort of quote-unquote clean most of the time. Not a big drinker. Again, I've based this off comments and messages that I've received. She has 2 or 3 glasses of wine a week. She's unable to run. That hurts her knees a bit, but she can cycle, walk, and lifts weights. And her main goal is to improve her bone mineral density. She was told that would be a good idea, and her mother has had several fractures. And she would also really like to lose some belly fat and, of course, stay cancer-free, which she's now been for 3 years. So that's the profile that we're considering here. You just mentioned then it gets really, really hard to sort of lose weight, build strength as someone starts going through perimenopause and then into post-menopause. Why is that?
During perimenopause, because there is a shift in the estrogen-progesterone ratios, there tends to be less and less progesterone that is being produced because there's more and more anovulatory cycles. So we have a down-regulation of not only our progesterone receptors, but also some of our estradiol receptors, because progesterone is not countering estradiol, so there's not as much of the stimulation. The other thing is there's a massive shift in gut microbiome. So when we're looking at natural hormones and how they are activated, we have first the hepatic response, where the hormones go to the liver, get bound by your sex hormone binding globulin, get excreted in the bile into the intestines, and the gut bugs there unbind it and shoot it back out into the system, where then your sex hormones work. When you stop having as much estrogen and progesterone, then you don't have as much coming into the gut. So then you don't have as many of those gut bugs that are going to increase the diversity. We see an increase in the amount of Firmicutes, which is the gut bugs that are responsible for obesity and visceral fat gain, and a decrease in the Bacteroides that's responsible for lean mass and I guess general health, they say. So when we're looking at body composition shift, we see that it is an affect of less response of these estrogen progesterone receptors, as well as a change in the gut microbiome. When we see one of the first telling signs is women will lose power and strength. And they're like, what's going on? I still have lean mass. What's going on? Because estrogen, not only is it responsible for stimulating your satellite cell for lean mass development, but it is tightly tied to myosin. So myosin and actin, myosin is a strong bond. It's for a muscle contraction. So you don't have estrogen, or you have different doses of estrogen, that myosin is going to have a strong bond with actin. So we start to lose, strength and power. The other is it is directly affects how much acetylcholine is being stored in the vesicles in the gap junction. So you have less estrogen, you have less acetylcholine. So then you have less of a neuromuscular response for actually stimulating those muscle fibers for a contraction. So this is another reason why women start to lose lean mass. And when we look at the general recommendations of 150 minutes of moderate intensity activity, 2 of them resistance training, that's like the opposite of what women in perimenopause and postmenopause should be doing.
Mm-hmm. So
hear me out, I saw your face.
Yeah, with and I want to go into exactly what you would recommend for women during these phases, but based on what you just said then about estrogen. And so I appreciate in this kind of avatar, I mentioned that Naomi is not taking HRT.
Yep.
But would you say that HRT makes it easier to maintain strength and lose weight?
No. So when we look at what people are using for menopause hormone therapy, you can have microdosed doses, which then sort of has a hepatic response, but it's only 25% bioavailable as compared to what your body's naturally producing. So what I want people to understand about hormone replacement, it's not really hormone replacement, it's menopause hormone therapy. It is a therapy. And we know there's a really fantastic efficacy for people who are having significant issues and symptoms that interfere with daily life. So we see mood swings, hot flashes, night sweats, poor sleep, vaginal dryness, all of those things. And when it comes down to body composition, it doesn't have a true effect. We see it slows down the rate of change, but doesn't stop the change. We see that it can be used as a therapy to slow down the rate of bone mineral loss, but it is not a treatment for osteoporosis. So there's this misconception really circulating about hormone therapy, and the immediate response is every woman in perimenopause should go on it. But in reality, it is an individual thing, and we have to look at the fact that those people who are shouting that from the rooftops are not looking at nutrition and exercise. So when I said earlier, we look at an external stress to apply to the body that's going to create an adaptation. So when we look at Naomi and she can't use hormone therapy, that's sweet. She doesn't have to, because we can look at power training, right? And again, it's relative. What is heavy lifting to a 60-year-old? If she's never lifted a 15-kilo barbell, that's probably heavy to her, right? So we look at implementing that power-based stuff. And there's been some really fantastic studies that have looked at 70 and 80-year-old women who ditch the hypertrophy 10 to 12 rep range and actually get into the 70 to 80% 1 rep max and doing the 6 to 8. Not only do they increase their lean mass, they improve their bone density and proprioception. So their falls risk decreases. So this is what we're looking at when we're looking at women who are post-menopause. So it's not just about body composition. It's like, okay, if this is what's happening when you're 60, we also want to look forward to 70, 80, 90. How are we going to keep your quality of life? Resistance training is the critical factor here. Not only do we see it as the stimulus for central nervous system to kick in, without the use of estrogen. So if we're lifting heavy loads, then the central nervous system is going, oh gosh, we got to have more acetylcholine. We have to have a strong bond. We got to do something here because, what used to work isn't working for us. So we have a really strong response in that power training. We develop the lean mass, we get the power, we get the strength. Mm-hmm. We also have feed forward to brain health. So I don't know if you've talked to Louisa Nicola at all.
Haven't yet. I know her. I'm actually connecting with her in Sydney in, I think, 6 weeks. Yeah.
Oh, yeah. She's fun. But she's pointed a lot of really cool research out to me about the benefits of resistance training and the neural growth factor in the brain. So we know aerobic training is good for volume of the brain, but the neural growth factor is good at attenuating Alzheimer's risk. So if we look at what's happening with brain changes at the onset of menopause, we see a lot of brain changes and can be attenuated with resistance training. So if we look at Naomi, I'm going to be like, okay, you know what? We're not going to look at that 150 minutes of moderate intensity activity, because if you get into that moderate intensity, it's going to increase your sympathetic drive. It's going to increase your baseline cortisol, and it's not going to do anything with regards to recomping your body. You're not going to increase your lean mass. You're not going to decrease the visceral fat. You're not going to improve your bone density. We have to look at resistance training being the cornerstone of everything you do, with some true sprint interval training.
Interesting. So just so that people are across what you're saying there, when you're talking about sort of moderate intensity continuous training, we're talking about a slow, steady state jog or sitting on a stationary bike and kind of heart rate at about 60%, 65% of max heart rate. And while that's where I guess general population recommendations may be to get that 150 minutes in of that moderate intensity, you're saying we can do better. And
absolutely
for a woman who is in both perimenopause and post-menopause, we should rethink what that looks like, focus more on resistance training and high intensity. So let's go through that. I think it might sound for lack of a better word, counterintuitive for a postmenopausal woman to select a weight where they're only doing 6 reps. I think a lot of the time what I see is very small weights and doing very high rep, 20, 30s, and I think that's considered safer or
yeah, that's it's that social confound, because no one wants to see their grandma in the gym lifting heavy weights and doing deadlifts, right? Because it's just not in the mental scope. But from a physiological perspective, when they're doing that high rep, the 20, 30, it's a metabolic stress that puts them in that moderate intensity. It's not going to stimulate lean mass gain. It's going to stimulate that visceral fat. You might get a little bit of muscle tone, but it's not strength. Because that, again, is all about breaking down things, and we don't want to do that. And I'm not telling people who are peri and postmenopause to immediately go in the gym and do a 100-kilo deadlift. We phase people in. We get them comfortable. We want them to move well first. We want to find their anomalies. If you have osteoporosis, we look at having support. So we might use a Smith's machine instead of just a plain rack, right? So we're looking at what are the anomalies, what are the movement limitations, and then we have to apply load once we learn your mechanics to move well. And then when we talk about like bone mineral density, resistance training significantly helps with that, right? We see the load, we see the multi-directional stress from resistance training improves bone mineral density. Walking doesn't do it. It's not a multi-directional stress. Running doesn't do it. It's not a multi-directional stress. The two biggest things for helping with bone density is resistance training and jump training. So maybe you're jump roping as a warm-up. So you're getting that multi-directional stress through the bone that is going to stimulate bone growth and density. So running's not it. And so when you tell people, okay, go on a moderate intensity walk, I'm like, no. If you're a guy, that helps with cardiovascular health, but for a woman, it doesn't. It's not a high enough dose to instigate better vascular compliance, nor is it a strong enough stress to recomp the body, nor is it a strong enough stress to create any kind of lean mass and strength development.
So Naomi wants to recomp. She wants to try and shift a little bit of that belly fat. How much time does she need to dedicate to an exercise regime, and what would it look like? You mentioned resistance training and HIIT being the priorities, but what would that, or what may that look like over a kind of 7-day period? She can do something every day. Let's say she has 45 minutes to an hour a day.
Whoa, she has a lot of extra time because she doesn't need that much to work out.
Okay, cool.
And I say that because when we take away the menstrual cycle and we look basically back at sex differences, women's bodies, again, are very endurant. We don't need volume when we get into that post-menopause stage. So the body is very, very, very good at going long and slow and putting on fat. So we need something that is polarized from that. So resistance training, we say 3 when you feel more comfortable, preferably 4 resistance training sessions a week. And then 2 to 3 true high intensity sessions. So one of the, like if I base it out, it's like one of my favorite workouts to get people to understand what I mean by lifting and true high resistance training is a buy-in, where we look at a buy-in of 10 deadlifts at 75%, and then immediately getting on an erg, either a cycling erg or a running erg, and sprinting as hard as you can for the remainder of a minute. Then you have 1 full minute off. Then you do it again, and you do 6 rounds of that, done and dusted, 12 minutes total. So it's every other minute on the minute for the most part. And people are like, that's enough. I'm like, yes, if you're doing it right, that is enough. You're getting the loading from the deadlifts, and you're getting the high intensity, true sprint interval training, because you're trying to accumulate more meters or more distance every time you get on that erg. So you have 6 tries to get faster and faster. So it's that motivation to go full gas, knowing that you have a full minute of recovery. And people are like, what? No, I can't do that when I'm 60. I'm like, yes, you can. You've been mentally prepared that you can't, through all the nuances of society telling you that when you hit menopause, you're frail and you're doomed to be fat and just kind of a burden to society. But that's not true. It's not true at all. You're fully capable of doing this kind of work, but it's relative. Like that deadlift might be the bar. It might be 2 5-kilo or barbells at the start, but it's the movement and that intensity that we're after.
Right. I asked you this question earlier when we were talking about Alex, but in this kind of context here, when it comes to shifting the belly fat, how important is this training piece versus the nutrition piece?
Training is really important, because we need that stimulus. We need that external loading. We need that stimulus to support the body, because we don't have estrogen, progesterone. Nutrition does play a role as well, because we know we can't out-exercise a bad diet. So then when we look at nutrition, protein super, super important in peri and post-menopause, probably more so than premenopausal, because we have anabolic resistance as we get older. So it takes more protein to get that effect. So we look post-exercise protein for women who are peri and post-menopause is at 40-gram dose, as opposed to what we generally hear of a 25, 30-gram dose, because we need more for that tipping point. And regular protein across the day is so important. And we find that it's really difficult for older people to eat that much protein, because they're, I'm not hungry, but we really push that protein and good carbohydrate from fruit and veg for that gut diversity. So we match those two together and we start to see significant change. And
is fasting still a no-no? Do you still like the sort of 15-gram protein prior to a training session in the morning?
Yep. Especially early postmenopausal women, because they already have a higher baseline level of cortisol. So they're already in that sympathetic drive. They already have the predisposition for putting on visceral fat. So we need that protein, and we need the hypothalamus to be like, oh, okay, yep, there's some stuff coming in. I'm good. I don't have to have the signals to put in that extra abdominal fat.
Mm-hmm. And is there, or are there any supplements or particular nutrients or herbs or adaptogens that would be different to what we spoke about earlier that may be more relevant during this period of life?
So I'm going to say creatine again, especially now when we're looking at brain changes and brain health. And yep, 3 to 5 grams daily. And then depending on how stressed she is, right? I really try to get people to use ashwagandha when they're in this early post-menopause phase, just to really try to get them out of that sympathetic drive that's new, and really relearn that parasympathetic. I can also pull a lot on Huberman's non-sleep deep rest, which I think is yoga nidra for the first part, and implement that as well. Anything that gets that parasympathetic drive is going to help with body recomp, as well as getting that really significant sympathetic response downgraded.
Mm-hmm. Regarding that body recomp, does Naomi need to be in a calorie deficit to shift the belly weight, or with the right training and nutrition, can the body composition just change without being in a kind of calorie deficit per se?
Yeah, so unfortunately, the automatic response when people start to hit peri and postmenopause and they're putting on the weight is calories in, calories out. I need to be in a calorie deficit. But then this leads people to being in low energy availability and RED-S. Yes, the metabolism does slow down a little bit when you hit postmenopause, but we can counter that with protein intake. So it's not about calorie deficit as it is about macronutrient redistribution. So we're looking at that higher amount of protein, a little bit lower amount of carbohydrate, and good amount of fat. So instead of hitting about 40% of calories coming from carbohydrate, we're dropping it down to about 35. And we're having protein really up there, hitting that 2 grams per kilogram of body weight. Because we want a lot of fruit and veg for that gut diversity is super important, because we've had that shift in perimenopause, but we need that protein.
Mm-hmm.
We need that protein for lots of body functions as well as lean mass.
We haven't spoken about dietary fat much, but how important are fats within this discussion as well, both, I guess, for Alex and Naomi? Some people are perhaps scared of eating fat, thinking that fat will make them fat. What's your view on fat, and what sort of advice would you have for both Alex and Naomi here?
Yeah, so fat, I think so many women are afraid of it from the 90s of, high carb, low fat. But when we look at fat, it's really important. It's good for our myelin sheath, brain health. It's good for satiation. We look at it as a good means for our gut microbiome. And we want to look at it as plant and a little bit of animal fat. Like, don't be afraid of it. It's really beneficial and it's necessary.
When should someone or should a woman in her 40s, let's say, who is hasn't done a blood test for a while, hasn't been to see the doctor, what's your advice with regards to getting blood work done and speaking to a doctor about that perimenopausal kind of phase of a woman's life?
Yeah, so you don't need any blood work for perimenopause, the menopause transition. What you need is somebody to talk to you about what's going on symptom-wise. So if you're starting to get a new onset of irregular periods and you're 46, that's expected. Just like if you start growing when you're 9, no one's going to say, wait a minute, why are you growing? Well, we all expect puberty to come at that time. But if you started growing when you were 4, then people are like, wait a minute, that's the wrong time. So if you're having symptoms that we associate with the menopause transition and you're 36, you absolutely need to have testing. But if you're having symptoms associated with the menopause transition and you're 46, you don't need testing. It's probably valuable to check a thyroid hormone level just to make sure, because you know what? 2 things can happen at the same time. And if you're not up to date on your screening for diabetes and your cholesterol and all those other things, absolutely. And often that's a good time to check in and say, hey, we haven't had your blood pressure checked for a while. Hey, we haven't had your cholesterol checked. So there's good reasons to check in.
A bit of an audit.
Yeah, but you don't need hormone testing to make the diagnosis of the menopause transition or menopause.
Right. I've seen you talk about the Dutch test. Is that what it's called?
Yeah,
I have spoken about this previously in another episode, but I think it's worth touching on again.
Yeah. I mean, this is some kind of dried urine test where it tests supposedly for estrogen metabolites. And, whether it's accurate for that or not, I can't speak of it, but it's completely clinically meaningless. So you don't need it. So what happens is people get this done. And then, of course, they get all these specialized hormones prescribed to them, or they're told they're estrogen dominant, which is a medically nonsensical term, or they're progesterone progesterone dominance, and these things mean nothing, but they sound good, right? It sounds really good for somebody. Oh, you're estrogen dominant, really? Oh, and so then they get these complex hormone combinations prescribed to sort of match this profile, and then of course you need to be retested to see if things are falling into place the way you want them to. And it's a hormone testing for people over the age of 45 is a way to get repeat business. That's really all it is, because they change all the time and we don't manage menopause based on hormone levels.
Where's this estrogen dominance idea come from, and why is that a myth?
Well, it's always hard to explain disinformation that's kind of like somebody dreamed up. I think some of it comes from, there was a family doctor in the 1970s who had these bizarre concepts about progesterone and things, and that kind of infiltrated into naturopathic medicine. So I think it's really a naturopathic concept. I think some of it's a misunderstanding of what polycystic ovarian syndrome is. I think some of it's a misunderstanding of the normal menstrual cycle. You know, if I ask 5 people what they've been told about estrogen dominance, I get 5 different answers. So, and I once Googled it just to kind of see, and I got a whole bunch of different things from different people. So I think it's, it's the Emmanuel Goldstein, like in 1984, right? It can be whatever you want it to.
Sounds a little bit like adrenal fatigue.
Yes, it's exactly like adrenal fatigue. Yes, that'd be a great analogy.
Right. Sometimes I think someone might listen to this and hear that and feel almost like a personal attack, because that's a diagnosis they've been given. And I would hate for someone to feel like that. But do you ever have patients that kind of express that? They almost feel like when you're presenting that information like you are now, that it's insulting?
So in the office, I would never say, you don't have estrogen dominance. That's a crazy diagnosis. In the office, I would say to somebody, I'm here that you have symptoms. I absolutely believe that you have symptoms, but your symptoms aren't due to estrogen dominance. Your symptoms are due to X, Y, and Z. So, and I think that's the corollary or the important follow through is when someone's been diagnosed with adrenal fatigue, or they've been diagnosed with estrogen dominance or progesterone dominance or whatever, they have symptoms.
Their symptoms are real.
Their symptoms are real. Absolutely. They've been misdiagnosed.
Unfortunate. A lot of the time, menopause is spoken about in a very kind of negative sense. I've seen you write about the grandmother hypothesis.
Yeah.
Can you share that with us?
Yeah. So it's true. And what people don't realize is a lot of the negative things that we hear about menopause is really actually part of pharma marketing from the 1960s. It's kind of a carryover from this book called Feminine Forever. Because the worst thing that could happen to you, as a woman would be that you would have a disease that would make you unattractive to men. That's the worst possible thing that could happen. So if you want to sell a new product, you need to make a disease, right? So the grandmother hypothesis, which also is also known as the wise woman hypothesis, because not everybody's a grandmother, is this idea that there is value in having a post-reproductive lifespan. So most mammals reproduce and then die. It's, you've about a year after you're done, or depending on that kind of animal, maybe it's a few months, but you're basically reproducing until you drop dead. But humans don't do that, right? Humans reproduce until they're kind of their early 40s. Fertility drops off dramatically, and then they keep on living. And this isn't, a lot of people have this erroneous idea that this keeping on living is a new thing, but it's not. If you look at life tables, women have been living longer than men for, more than 100 years. And, the ancient Greeks were accurate about the age of menopause being 51. And they couldn't have been accurate if everybody was dying before then, right? They just couldn't have been. So what studies tell us is that when there is a menopausal woman, a woman who's post-reproductive in the family unit, her children have more children. So it's genetics, the long game. We're all here, Dr. Ponzer, I had him on my podcast, and he said that, life is as turning energy into offspring. So we all think about it as the next generation, but it's pretty smart to actually be invested in the grand generation too, right? So there are several studies that look at birth records, one which looked at studies from the 1700s in both actually Finland and Canada, and found that when children lived in the same family unit with their mother, they had more They had more grandchildren. When they moved away, that effect was lost. So it wasn't genetics.
So the grandmother is enabling the mothers to have more children.
Think about it. It is a lot of work to have an infant, to feed an infant, to raise an infant in our harsh environments. Think about what it was like 10,000, 20,000 years ago. And there's also data from Hadza women in Tanzania where they've looked at how much work a grandmother does. And when her daughter is pregnant and breastfeeding, she's spending 37 hours a week foraging for food. That's a lot of exercise, right? And she's providing the bulk of the calories for the family unit. So if you can offload tasks, it's easier to reproduce.
Right. If this is nature's way, why intervene with hormones? Why not just let it run its course?
Well, I think that we have big brains for a reason, and big brains let us work our way out of things. And so you could also say, well, then, why have phosphodiesterase inhibitors for erectile dysfunction, right? Why not let nature take its course? Why treat people with cancer? Why treat anybody? Because we have big brains, and because we think that alleviating suffering is a good thing. And so if you're suffering with symptoms, be it bothersome irregular periods or hot flashes, we have science that can tell us how we can help you. Just like we have science to keep our food refrigerated so we don't have to get food poisoning, and science that lets me, clean my house with chemicals so the salmonella from my chicken isn't going to kill us all. And so I think it's really just comes down to that, is that, we have science that tells us every single person doesn't need to be on hormones, right? That's not what the science tells us. If you don't have symptoms, if you're not at high risk for osteoporosis, you don't need hormones. And if you are at high risk for osteoporosis and you can't take hormones, you don't want to, you know what? There's other medications. So there's options.
So someone's health is not just going to fall apart if they're not taking hormones.
No, absolutely not. There are, like I said, there are people who do better with hormones and people who don't need it. And a great example is pregnancy. There's some people who sail through their pregnancy. They say, I felt the greatest I ever felt in my entire life. And there's other people who look at them and are going, what? That was the worst I ever felt, right? Or some people sail through puberty and other people have terrible acne. So, we have all of these different ways that we're put together, and probably different enzymes metabolize things, and, are also life experiences. We have a lot of data now about adverse childhood experiences having an impact later in life. And so there's many things together in our soup that give us these individual experiences.
So I get the feeling from kind of listening to you that you feel like the pendulum may have swung too far almost, from a total fear of hormones, to certain corners of the internet and media seeing hormones as a magical cure.
Yeah, I mean, I've been doing this a long time, so we're coming around the barn again. So, when I was in training, it was estrogen for everybody. 80% of women in menopause were on hormones. Everybody. You're 62, you're coming in for an annual check. Oh, we should put you on hormones. That's what we did. Then the pendulum swung the other way. And that's how we are in life, right? Humans are like, we all want everything to be on or off, right? So it's, but with most things, the answer is more in the middle. And so we're starting to see some people making false claims about what hormones can do. And I think that unfortunately dilutes the message that this is a really great option for a lot of people, but it's not something that everybody needs. And it's not like you're missing out if you're not taking them. If you don't need them, you don't need them.
What are some of the problems that you've observed?
Well, certainly, people who get cancers from taking, unregulated hormone concoctions.
Compounded.
Or just taking high doses of estrogen without progesterone because they're told they're progesterone dominant. People afraid to take hormones and suffering in symptoms because they were told they were estrogen dominant or have too much toxic estrogen. And so, I see both ends of it. I see people who are on too much and having problems. I see people who are too afraid. And I see people who end up paying large amounts of money for things that they could get from their insurance company for $30, because they've been sucked into, what they read online. And so, there are really good practitioners out there, but of course, our attention always goes to the ones that are making the bolder claims, I would say.
Yeah, I saw you made a comment saying that you could not pay me to take compounded hormones.
Not enough.
Can you explain that to someone?
Yeah. I deserve to have a medication where I know how much is in each dose. I deserve to have a medication where I know that's what it says. I deserve a medication made in a lab that's clean, that hasn't been cited by the FDA for problems. That's what I deserve. I deserve to know when I put a patch on my body, how much is getting into my bloodstream. I know all of that with a pharmaceutical hormone. With compounded hormones, I know none of it. There are some studies that show that with some compounded hormones, people are absorbing very little of the hormone. So I know this is a shocker. I mean, obviously I'm exaggerating, but it takes decades of research to figure out how to get a hormone through the skin into your blood or how to absorb it, right? Because we didn't evolve to eat hormones, right? We evolved to have them be dumped into our bloodstream. So all of that research doesn't exist with these compounded hormones. The idea that you can just, mix up some estradiol powder into some Vanicream and put it on your leg and it's going to get absorbed, really? Where's the data to show that's going to get absorbed?
So if these are more expensive and there's no data, why then are people led to believe that they're the better option?
Well, probably the same reason why people think a Mercedes is better than a Toyota. Right? I mean, I've had both. I actually prefer my Toyota, a lot less expensive. It's the marketing. It's the marketing. And they, again, play into this idea that big pharma is evil, even though these companies are profiting wildly. And they make false claims. They're associated with blood tests, which gives you the illusion that you're getting this bespoke thing. I'm special. Of course, they should have to monitor my hormones individually. And I get why people would think that if you don't know the medicine.
I've heard that because based on what you were saying earlier about absorption being different, one of the responses to that I've heard is, but my doctor is testing my levels to see how effective they are.
Well, you're going to a bad doctor. That's what I would say. We do not manage hormone therapy testing levels. We absolutely do not. The commercial tests for estrogen are not designed for that. They're designed for diagnostic purposes. They're not designed for therapeutic purposes, right? And we have great data. We know that what dose of hormone in a patch or in a pill works for symptoms. And what I see is the majority of people, when things don't work, it's because they were, again, oversold what the hormones would do. Because I don't have those people in my practice. I don't have people coming in needing higher and higher and higher doses because I counsel them appropriately about what they could expect from the hormones.
What does bioidentical hormones mean?
Yeah, I hate that term. And I know a lot of people use it, and I probably irritate a lot of people by my anger about it. But it comes from the sort of alternative medicine world because it came from these compounded bioidentical hormones, which entered the market after the Women's Health Initiative sort of created that whole fuss about what we should do about hormone safety. And they said, of course, they're safer because they're bioidentical, because the Women's Health Initiative used Premarin, which is conjugated equine estrogens. And they're saying, well, we're using the identical estrogen from your ovaries. Well, there's a few problems with that. The estrogen from your ovaries is also what gives you breast cancer and can give you endometrial cancer. So just because hormones in your body doesn't mean that it's safe. Everything's has to be studied, right? Because when you're taking it as a pharmaceutical, it's not the same thing. So there's that. And there's also, and this is a pharmacological sticking point, but they're not truly bioidentical. They have a different ratio of carbon isotopes, 12C to 13C. If they were identical, they'd be the same. So that irritates me, that the association with alternative medicine irritates me. And it's used as marketing. The reason transdermal estradiol is the best option for menopausal hormone therapy is not because estradiol is the same as the estrogen made by your ovaries, or almost identical, it's because that's the one that's been studied and shown to be effective.
So that's a patch or a gel?
Patch or gel, and there's a lotion and I think a spray.
Okay. So that's your preference over the pill?
Those are the recommendations from all of the menopause societies. Yeah, to start with transdermal, because there's a lower incidence of, we believe, a lower incidence of clots and cardiovascular complications.
How does a doctor work out dosage? Is that something that's in the guidelines? I saw there was some controversy, for example, in the UK with some dosing issues. What's the kind of protocol that exists for dosing these things?
Well, there isn't any controversy from true experts, I would say. So we know, the people have studied it, that, that a standard dose of menopausal hormone therapy is a 50 microgram estradiol patch, or whatever the equivalent of spray or whatever is. There's not always sort of like truly, it's not always necessarily 50, but you'll be able to see on the product insert what's the comparable amount of sprays or pumps or whatever.
And how frequently are you putting that patch on?
Well, it depends. Some are twice a week and some are once a week, but it's the same cumulative dose. And the good way to think about that is, so at the start of your menstrual cycle, your estradiol might be, 20, anywhere between sort of 15 to 30, I think it's picograms per milliliter. I could have the actual units incorrect. And an estradiol patch gives you 50. So throughout the cycle, then your hormone levels go up and then they go down. So a 100 microgram patch would give you the average amount of estrogen that you would have in your body before menopause. And you obviously don't need that amount. So a 50 microgram patch is about half that amount. And studies tell us that that dose eliminates hot flashes or significantly improves them for over 80% of people. That's the dose that is very effective. Lots of people manage with a lower dose, 25 micrograms. And that's again why testing isn't a good idea. Because I remember I told you that at the beginning of the cycle, your levels could be as low as 18, 19, 20. Well, below 20 is menopause, but that can also be the start of the cycle, right? So it's not the levels that matter. It's the response to treatment that matters.
Does that change post-menopause in terms of, do the levels, is testing hormone levels more relevant post-menopause, or same thing?
Yeah, no, it's not recommended at all. We treat solely based on symptoms. It's symptomatic treatment. And that's really hard, I think, for a lot of people to wrap their head around, because it's not something that we do with a lot. People often think about like thyroid disease, right? Like my son has congenital hypothyroidism. He's got to get his blood work checked. When he was growing, he had to check more often, and he has to get it checked, once or twice a year to make sure that the dose is the right for him. If we waited till he got symptoms, then he'd actually be too late or not optimal. But that's not what menopausal hormone therapy is. It's not a replacement. It's a therapy for symptoms.
So what was the controversy about in the UK recently with dosing?
I think there's some providers there that recommend doses that are higher than you would say would be in the birth control pill, they're putting people on, mega doses. None of the safety data we have is for those doses. That's really important for people to understand, that when we're talking about, the low risks of breast cancer, which are very low, we're talking about the low risk of clots, all these very low risk of things, those are with the standard doses. When you start talking about these higher doses, we have no safety data. We don't know. We don't know how much progesterone. So if you have a uterus, we have to give you progesterone or progestin, or you'll get uterine cancer. It's a very high rate. We don't know how to match those doses. And so what I've heard is people have been increasing their doses because they felt unwell. But we're not looking for wellness when we prescribe estrogen. Is it helping your hot flashes? Is it helping your sleep? For people in the menopause transition, some people it can help with mild depression. Is it helping with these things? We know the doses that should help. So if it's not helping, then it might be something else. Sleep apnea can affect your sleep. Sleep apnea can give you night sweats. Some people have depression that needs antidepressants, right? So there are other things you have to consider. So it's really important that outside of the standardized doses, we just don't have safety data. And I've been doing this for a long time. Like I said, I was practicing when we gave estrogen literally to everybody. I'm not kidding. Like, I think I once put an 82-year-old on estrogen because that's what we thought was the right thing.
Whether they had symptoms or not.
Yeah, well, they can't. I heard I should be on that estrogen. My friend's on it. Yeah, sure, here you go. We gave it to everybody because that was the standard of care at the time. And I've never had to give people over the standard doses of estrogen.
So now the indications are those acute symptoms, or if someone has osteopenia or a family history of osteopenia or osteoporosis.
Yeah, so symptoms that could be treated. And I'll take vaginal estrogen out of the picture because vaginal estrogen is, many people need that and can be very helpful for dryness, pain with sex, prevention of urinary tract infections. But systemic, so hormones going through your bloodstream, would be for hot flashes. It's the gold standard of treatment, probably the most effective. And there's no reason to suffer. If you're suffering, there's treatment. Night sweats, which are probably, from a health standpoint, the bigger issue because chronically disrupted sleep is not a good thing, right? You're waking up 3-4 times a night. And then what happens is you throw the sheets off. And then after the hot flash, you're cold and you're lying in this sweat. And so then that wakes you up, right? And so it's this on and off with the sheets all night. That's not good for you. Mild depression, that's not a true indication, but there's some good data to back that up. And so those are the reasons to go on it. And there are some other reasons that might fall out of the standard guidelines, but with appropriate counseling, you could discuss it. So for example, joint pain is a common symptom in the menopause transition. There's data to show that hormones can help, but they don't help that much. Like, I don't have the numbers right off the top of my head, but if 60% of people get joint pain, then with hormones, it's like 45%. So like a 15% improvement. Does that mean it's wrong to try? Well, no, if you're really suffering, because we don't really have anything else. But you should be told it's not a standardized treatment. We're in this kind of area where you're suffering. These are the risks, and you want to give this a try to see if it makes a difference. So
where does cardiovascular and dementia prevention fall?
We certainly don't recommend hormones for dementia prevention. That was something that we used to recommend, and it's no longer, an indication for that. And we also don't recommend it for cardiovascular prevention. So really, people should be looking for lifestyle changes, exercise. And I always tell people, look, if you only have one thing you can do in menopause, it's exercise.
I think a number of women who experience hot flashes but are contraindicated for estrogen, maybe they've had a history of cancer, are looking for other alternative treatments that might work and help with those hot flashes. And I saw you post about Veoza.
Yeah, fezolinetant. I think that's how you pronounce it. So it's a new drug that works on the neurokinin B receptor. So hot flashes are very complex biologically or biochemically or both. And we don't really understand them completely because obviously we can't dissect somebody's brain while they're having a hot flash, right? But basically, we have an area of our brain, the candy neurons, and part of their job, they do many things, is they signal about heat. And so they want to tell you that you're hot. And estrogen suppresses the kindy neurons. And with menopause, without estrogen, that area of the brain actually grows. So you send more heat signals. And then what happens is you have another part, you have the kindy neurons make neurokinin 3, which then stimulates them to send more heat signals. So fezolinetant blocks that neurokinin 3 interaction with the kindy neurons. And it seems to be in studies, it hasn't been studied head-to-head with estrogen. Probably a little bit less effective, but certainly worth trying. Absolutely.
And someone with a history of cancer can use that?
Exactly. History of cancer, breast cancer, endometrial cancer, somebody who just doesn't like how they feel on hormones. Some people don't want to take hormones. I mean, we all have a different sort of gestalt about like what makes us happy or what we want to do with our bodies. I'm all for having more evidence-based options. And then there's other medications like gabapentin, venlafaxine, and a few other, a couple of the other antidepressants can be used as well.
What about supplements during perimenopause and menopause? There's a whole lot of things that is marketed towards this part of the population. Are there any supplements that are effective? Are there some supplements that are widely marketed that you would say are BS?
Yeah. So I always tell people, let's separate it out to single ingredient products and multiple ingredient products. And then in the single ingredient products, let's just look at vitamins or minerals. So there is some evidence that some people will do better with a calcium supplement, not for symptoms, but for, maintenance of their bone mass, right? If you're not able to get enough calcium in your diet. And that vitamin D may also be important for some people, although the data is not that great, but it's probably no harm from taking it. And then there's everything else, everything that's not calcium or vitamin D. And there's really no good data for any of it. I wouldn't take any of them. I mean, I always quote people this study. There was somebody looked at black cohosh. And they wondered why do some people work for and some people it doesn't? Well, first of all, we know that the placebo response for hot flashes in studies is really robust. It's like 30 to 40%. So if you're only doing a 4-week study or you're just doing a non-placebo controlled study, lots of people are going to do great on your product because everybody's going to have benefit, or not everybody, but 30 to 40% of people are going to do great in 4 weeks because the placebo effect. So there's that. But the other thing that people don't realize is you literally have no idea what you're taking when you're taking a supplement. So when I take a pill from a pharmaceutical company, I can guarantee the exact amount that's going to be in there, probably with whatever their standard of error is that they've agreed with the FDA. Like I said before, it could be dirt from someone's backyard. So somebody wondered, what was actually in black cohosh? Why were some people getting better and some people weren't? And there's a big problem with supplements is many of them are adulterated with pharmaceuticals, right? So there's also that issue, or with designer steroids. That's another issue, especially with weight loss drugs or bodybuilding drugs. And so they found that I think it was 30%, I can't remember them off the top of my head, but something like 30% of black cohosh pills contained no black cohosh, none.
Is that mostly a United States thing? Is that the same in Canada?
I think it's the same. I mean, it'd be the same in Canada, whether it's, whether it's the same everywhere around the world, I don't know. But capitalism is it live everywhere. But so then they said, well, what is in these black cohosh samples that doesn't have black cohosh? Well, so black cohosh is native to North America, right? So they wondered, we'll be generous and say maybe they just picked the wrong herb next to it, right? Contained a plant not native to North America. So it wasn't an accidental, we picked the clover instead kind of thing.
A few ingredients were being mixed.
Yeah. So imagine if you went to the grocery store and you were buying a can of corn and 30% of the time you open the can of corn, it would be black beans. You'd be pretty annoyed, right?
I'd be pretty happy. I love black beans.
Oh, okay, we have black beans. But what if the recipe was corn? You had to have corn.
I'd still be happy. I'll eat black beans every day.
Oh, I don't like them. I like pinto beans better.
Yeah, pinto beans are good too.
So it's like that. People would be on the news, right? It would be a news story. So I would say with every supplement, the quality of evidence is very low. These companies are making money off of you. And the question is really, why have they not done robust studies?
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.